हाँ हाँ
Yes, ma'am. Give me 2 minutes. It's going live.
करना अगर वीडियो तो आप वहाँ कर सकते हैं क्लिक करके।
ये हमारा म्यूट है, देखिए तो नहीं ना, ये तो अनम्यूट अभी चल रहा है। इसको अनम्यूट करने के
এই অপূর্ব
হাই
তোমার
ডক্টর
ভয়েস
অপূর্বা।
খুব কম শোনা যাচ্ছে।
না স্যার, এখানে আছি স্যার, বাস
তোমার
আপনাদের
তোমার
আশীর্বাদ নেওয়ার
তোমাদের
জন্য।
কথাগুলো খুব লো ভলিউমে শোনা যাচ্ছে।
আচ্ছা, ওকে
স্যার আপনি ওটাকে ইয়ে একদম ফুল ইয়ে করে দিন, ইয়ে এসে যাবে। আমি
Very good evening, all of
নমস্কার
you.
স্যার, আমি অর্পিতা, দেওঘর থেকে অর্পিতা।
Very good evening. Very good evening, all of you. We are live now on YouTube.
মিউট টাচ করবো, ওটা আনমিউট।
We are live now on YouTube.
কিছুই না, বাস থাকুক।
So I would like to give you a warm welcome to all the delegates and all the faculties for being present here for a common agenda of Happy Learning Masterclass webinar series, which is in association with Bokaro, Dhanbad, Diodar, Jamshedpur, and Ranchi Gynecologic Obs and Gynec Society. It's the 209th edition of this masterclass Happy Learning series with the theme of Art of Vaginal Surgery from the makers of Core 3, C Hope, and Diter Hope. First of all, I would like to introduce one of the key guests, which is Dr. Apurva Datta, who is the National Coordinator of Foxy CME Workshop of Safe Abortion and Contraceptive Cafe 2020.
Thank you so much. Thank you so much, Riyar, for such a kind introduction. I think we should focus on the academic also. Okay, so thank you so much. So before we start, pranam and johar to all of you. It's give me the immense pleasure to welcome you all in the 209th episode of the Happy Learning series, which is a brainchild of none other than but our very dear and respected Dr. MC Patel, sir. Again,
Yes.
Sir doesn't need any introduction, and I am really, it give me immense pleasure that previously also I was part of Happy Learning series, and when it started in Jharkhand, this time I am also part of this. So I welcome MC Patel, sir, virtually to the land of Bhagwan Birsa Munda. So thank you so much, sir, for organizing this such a beautiful webinars and a topic which is really close to our heart, the art of the vaginal surgery. So about MC Patel, sir. Sir doesn't need any introduction. Sir is very dynamic. Probably every one of us not only see but meet MC Patel, sir, once or the other time. Sir is the past vice president, Foxy, and what not. So before that we start, we all know when we start something new, we always getting the blessings of our Almighty, our God. So before we start, I just introduce all the dignitaries to please come forward for a virtual lamp lightning. Thank you so much. So we all know sir is our candidate. Yes, I am really thrilled to say sir is our candidate for the Foxy president and the election year is 2026. Sir is known to every one of us, and definitely from Jharkhand, we wish from all of us, we wish you all the very best, sir. So before
Yes.
I start, this webinar can't see the day of light without our convener, Dr. Monica Umarban. Again, she is the chairperson elect of the Public Awareness Committee, and our wonderful coordinators, Dr. Monica Gupta, ma'am is the past president of Alvar Society, Dr. Deepika ma'am, again very dear senior to me, a senior consultant from Delhi, Dr. Shatabdi, again very dear friend of mine from, from Siliguri, Dr. Niveda Datta madam, again doesn't need any introduction. And she is the past president of Bokaro Society, and Dr. Megha from Kulberg, and she is again the very senior consultant of the Kulbergi. So I welcome you all, and I just want to hand over to our dynamic person and our own candidate for the President Foxy, Dr. MC Patel, sir. Over to you, sir, to introduce our chief guest.
Thank you, Dr. Apurva, for kind word. Something wrong with my video, so I may not be visible, but hopefully I should be audible.
Yes,
Yes,
sir, we can hear you.
Yes.
We can hear you, sir.
It gives me immense pleasure to welcome you all on 209th episode of Happy Learning Masterclass web series. I welcome Dr. A.K. Devdas sir, who has kindly consented to be chief guest to bless this webinar. And I still remember we shared room long back in 2011 at Ambala. Alok Devdas sir, do you remember? So till then, I am very much close to A.K. Devdas sir. He is always with us in any of our academic activity. So welcome, sir. One more guest of honor, Dr. Usha Nath madam. She has joined from Chicago. It shows her love and affection to me. I am always blessed with her blessings. So welcome, Usha Nath madam. One more guest of honor, Dr. Pratibha Sahai madam. She is also always with us in any of our academic activity. Dr. S.K. Das sir. So he is also always with us in our academic activity. So welcome all guests of honor. I also welcome learned chairperson, Dr. Aarti Shukla, Dr. Manju Banker, Dr. Sheshi Iyer madam. They are going to chair very interesting session, and talk is delivered by Dr. Archana Kumari madam. Classification and etiology of prolapse. I also welcome one more set of chairperson, Dr. Pratibha Rai madam, Dr. Sunita Jha madam, Dr. Meeta Sinha madam, and they are going to chair a very interesting session of troubleshooting in vaginal surgery, and Dr. Priyanka Rai is going to give justice to the subject. I also welcome one more set of chairpersons, Dr. Shivani Jha madam, Dr. Shashibala madam, Dr. Subrata Malik madam, Arpita Gandhi madam. They all are going to chair one more interesting session about hysterectomy, rising rate, matter of concern, ethical, social, legal, and whatnot. I also welcome two learned moderators who are going to moderate very interesting panel of troubleshooting during vaginal surgery, Dr. Suman Sinha and Dr. Mosmi Das Ghosh. I also welcome two learned experts, Dr. Maya Verma madam and Dr. Geeta Sinha Manki madam. They are going to put their expert comments during panel surgery. I also welcome all the learned panelists, Dr. Sujata Hota madam, Dr. Rita Thakur madam, Dr. Varuna Verma madam, Dr. Reena Barnwal madam, Dr. Divya Resmi madam, Dr. Preeti Yadav madam, Dr. Divya, Dr. Sweta Lal, and Dr. Sipra Sarkar. And my own team, Dr. Monica Umardan, convener of the series, Dr. Monica Gupta, Dr. Deepika Logani, Dr. Nivedita Datta, Dr. Satabdi Day, and Dr. Megha, all are coordinator to this series. And I also put on remark special thanks to Dr. Apurva and Dr. Nivedita. They both have helped me a lot for designing this program and execution of this program. So, art of vaginal surgery. We have very nicely chosen this subject for discussion, because vaginal surgery, naturally it is an art and it is domain of gynecologists, I would say, and it is our art, our surgery. So we have to be master for the same, and ultimate goal is to be helpful to our patient, not to end up into any kind of morbidity and not at all mortality. So considering this, for discussing this subject, Again, I welcome all the president and secretary of societies who have joined this webinar. Bokaro, Jamshedpur, Dhanbad, Devghar, and Ranchi, and all the delegates who have joined this webinar. Thank you very much.
Requesting Team Corona to please stop sharing slides and share the slides of Dr. Alok sir. Team Corona, can you share the slide for Dr. Alok Devdas sir?
Excuse me.
So,
It is a proud privilege, sir.
yeah,
Please
yes,
introduce, sir.
carry on.
Yes. It's a proud privilege to introduce Dr. Alok Devdas sir as the chief guest for this webinar. He has been the Vice President of Foxy in 2006, President of ISOBA from 2004 to 2006. He's also the Chairman of the ICOG in 2012, peer review of an International Journal of OBGY. He has also received the Korean Award and he has been the author of many books. He's the examiner in 8 universities and his paper inventions include paperless partogram, the growth tape, and discipline tape. We welcome you, sir, and we request you to please offer blessings. Alok, sir? Sir, please unmute yourself. We can't hear you, sir. Sir, it is still muted. Yes, sir.
Am I audible now?
Oh, yes, sir.
Yes.
Yes, sir.
Yes, sir.
Hello?
Yes,
Sir,
sir.
you're
आपने
audible
audible
now.
अच्छे. आपने
Yes,
audible, sir.
hello.
Am I audible?
Yes,
Yes,
sir.
sir.
Yes,
Also visible?
Yes,
yes.
sir.
Yes, sir.
I can't hear you very clearly anyway. So may
Yes, sir.
I
You're
start?
audible and visible.
May I
Team Corona,
start?
please stop slide so that we can see sir's video at the full screen. Yeah.
Monica, may I start?
Yes, sir.
Well, I'm grateful to Dr. MC Patel for inviting me as chief guest for this webinar. Now, generally, all gynecologists are supposed to be a vaginal surgeon as opposed to all other surgeries. So we learn it and learn it well, and we have to learn it. So it's a very appropriate topic to discuss so that we improve further, and we can do almost, we are doing all surgeries vaginally. Now, as regards this topic, I know Suman is the chairperson of this committee, and we know her for many years, a very efficient person. And through this, I have the opportunity of meeting all of you virtually, and I'm grateful and pleased about it. So I have nothing more to say. Just carry on. Very well designed, and my well, congratulations in what shall I say? Before election to Dr. M C Patel. He's a very good friend of mine for many years. Well, that's all. Please carry on. Thank you.
Thank you, sir. Thank you for sparing time for us to bless this webinar, and to me particularly, I always am indebted. Thank you, sir.
Thank you, sir. Thank you for gracing the occasion. I now request Dr. Monica Gupta, madam, to please introduce our guest of honor.
Thank you, Monica, for the opportunity, and congratulations to MC Patel, sir, for his consistent efforts in the academics. Our guest of honor for today are Dr. Usha Nath Madam. She was a past president from Rachi Society. Dr. Pratibha and Madam has done enormous work into the cervical cancer, and she is a senior colposcopist in the women's cancer prevention.
evening.
Ma'am, over to you for your kind words.
Good evening to all.
Mika,
Hello.
Ma'am,
Sir,
Usha Nath Madam.
Dr.
Usha
A.K.
Nath
Devdas,
Madam,
good
please.
evening.
Dr.
Dr. Patel.
Yes, yes, madam.
Rao.
Good evening. Because I am at airport.
Hello.
Yes, ma'am.
And I
My
congratulate and best wishes to this webinar. Sorry, the meeting is going on. Okay. Usadi,
yeah.
namaste.
Yes. Namaste.
Ah.
Namaste.
Going to Mumbai or
I,
Singapore? Right.
I am really
My best wishes to Dr. Patel especially. He will elect this
yeah.
time. This is my intuition. Thank you.
Thank you, Dr. Patel, for
Thank you.
inviting
Thank
me
you, Dr. Patel.
here. Thank you, Dr. Patel, for inviting me here as a guest of honor, even from Chicago. So I feel very honored. And presence of Dr. Devdas and S.K.
हम
Das
टाइम पर नहीं किए, हम तो 6:30 पे
and all others is a pleasure to be here. Having worked in this field for many years, I have come to appreciate how much the art of vaginal surgery can change a woman's life. It is a discipline that rewards patience, precision, and compassion. It reminds me when I was working in Glasgow as a trainee, my consultant was a very senior person, Dr. Tenen. He was a regional consultant. So he was very precise in his teaching, the art of vaginal surgery, being an expert, even in those early days. He really made sure that I followed his instruction in toto. For me, it was a gift to become a mindful, meticulous gynecological surgeon because it is very important to be meticulous in gynecological surgery. And it was wonderful to see how newer techniques now has improved the tools and made our work even safer and more patient-friendly and patient-centric. I'm grateful, genuinely pleased to join you all today. Thanks again, Dr. Patel. You are a gem of a personality and value knowledge and sincerely admire your dedication. And I wish you good luck for your 2026. We are all for you there. You will be the president next time.
Thank you,
Thank
Usha
you.
Nath madam. Thank you, thank you. You are always with me and you have always blessed me. My pleasure. I am lucky that way.
You're most welcome.
Yes,
It's
welcome.
a pleasure. Pleasure.
Thank you, ma'am. Thank you for your kind words. Next CV, please. Professor Preeti Bala Sahai, ma'am. She is an ex-professor, HOD in Department of OBGY, Rajendra Institute of Medical Sciences for 10 years. She has got 38 years of experience in different medical colleges in Bihar and Jharkhand, and is a external examiner for the postgraduate and undergraduate as well as DNB students. She is an awarded visiting ICOG professor at KGMC Lucknow in 2010, and ex-member of Adolescent Committee and Foreign Exchange Committee of FOXY. Over to you, madam, for your blessings.
Dr. Preeti Bala Sahai Madam was just speaking from the airport and she conveyed
She was in the hurry. She was, I think she has to catch the flight. We go to the next guest of honor.
But we put in on record a special thanks to Dr. Pritibala Sahai. She had joined from airport when she is traveling somewhere, and it shows her commitment to this webinar, to bless this webinar. Thank you, Pritibala madam.
Dr. Sukanti Kumar Das is our last guest of honor, and he has done his MBBS from Kolkata, MD from PGI Chandigarh. He's FICOG, and he's a director of the Medical and Asarfi Hospital, Dhanbad, and he's a member of many society. He's an ex-secretary, and he has been chairman of different congresses of TSOG and BJGNO. Over to you, sir, for your blessings.
Good evening to all. First, at the outset, I must distinct subject of vaginal spectrum. Till date, we used to do vaginal many purposes, not only for prolapsed uterus, but also for undescended uterus for any other different pathological conditions. And nowadays it has been replaced by laparoscopic surgery also. And I am proud to tell you that I am a laparoscopic surgeon, and I prefer to go for laparoscopic hysterectomy than undescended vaginal hysterectomy. But in case of prolapsed uterus, we have to go for vaginal hysterectomy, and we are having very eminent speakers to speak about this matter, and we shall learn from them many other things. Thank you.
Thank you, sir, for your kind words.
Thank you, Das sir, for sparing time for us to bless the webinar. Thank you, sir.
Over to
Thank
Monica
you.
for the further proceedings.
Unfortunately, Dr. Archana will join late, so we will start with session 2 and Dr. Deepika will coordinate the session.
Dr. Deepika.
Yeah, so we will be starting with our scientific session now. And as Dr. Monica has just said, we will be starting initially with the session 2, for whom I will be, it's my honor to introduce the chairpersons for session 2, Dr. Pratibha Rai. So can we have Madam's CV, please? So Madam Dr. Pratibha Rai is professor and ex-head of department, Obs and Gynae, at SNM MCH Dhanbad. Ma'am is the member of Medical Council of India, ex-secretary of DSOG Dhanbad. Ma'am is the past president of Obs and Gynae Society of Dhanbad, and vice president of AOG SBJ. Ma'am, welcome, ma'am, as our chairperson. Can we have our next CV, please?
Thank you.
Next.
Yeah, can we move the CV?
Corona people.
Please move the CV to Dr. Sunita Jha's CV.
Okay, so I'll introduce Dr. Yeah. So our next chairperson for the session is Dr. Sunita Jha, ma'am. Ma'am is the ex-HOD of Gandhinagar Hospital and she has been the honorary joint secretary of Ranchi Obs and Gynae Society and the secretary of Ranchi Obs and Gynae Society 204-206. She's the organizing secretary of East Zone Yuva Foxy Conference and was organizing secretary for the ISOPAR 24th National Conference. Presently, ma'am is the vice president of Foxy Society from 2014 till date. And ma'am has got numerous awards and accolades in her name. Welcome, ma'am, as chairperson for our session. Yeah, next CV, please. Yeah, so it's my honor to introduce our chairperson for our second session, Dr. Meeta Sinha, ma'am. Ma'am is a fellow in pelvic endoscopy and has been past president of IMA and the past secretary of Bokaro Obs and Gynae Society. Ma'am is the director of Hope Hospital and Ultrasound Center and is the president of MPH Bokaro. And she has received numerous awards and is currently the past president of Bokaro Obs and Gynae Society. Welcome, ma'am, and can we invite our chairperson to introduce our speaker, Dr. Priyanka Rai, ma'am.
Hello.
Yeah, so can Dr. Pratibha, ma'am, can you unmute yourself and can you introduce our speaker for the session? Ma'am, आप muted है.
Ma'am, I don't need any introduction.
Am
So
I
can we
audible?
start with
Yes,
Oh,
our
yes.
agenda section?
Dr. Priyanka, let Dr. Pratibha ma'am just give you a short introduction. Thank you.
Okay,
Yes,
thank you,
yes.
ma'am.
Good evening, everyone. My sincere gratitude to Dr. Patel and whole team for inviting me as chairperson in this very important and beneficial session that is full of gems of the scientific session. And in brief, I want to say that Dr. Priyanka Rai is a professor and she is HOD in the AIMS Devghar. She is Secretary of Devghar Ops and Gynae, lifetime member of Foxy, lifetime member of ISAR and Indian Faculty Society, lifetime member of IMA, Associate Dean Student Welfare, AIMS Devghar, and she is Joint Secretary of telemedicine, member of Women Doctors Wing IMA Devghar, special interest in fertility, high risk pregnancy, and gynae oncology. Attended many conferences at state and neonatal level as speak panelist chairperson. She is going to deliberate a very interesting topic that is troubleshooting in vaginal surgery. Uh,
Very important.
Over to you, Priyanka. Over to you, Priyanka.
Thank you, ma'am. Thank you. Good evening, everyone.
Hello.
Uh,
Dr. Patel. Hello, Dr. Patel.
Yes, sir.
Could you hear me? Or
Yes.
was I
Yes, sir.
visible? No,
Yes, yes, sir.
Okay,
You are
just
audible and visible both.
oh, thank you. And thank you for inviting me. I have another sort of function to go. So may I leave?
Oh, yes, sir. Thank you, sir. Thank you for sparing time for us.
No, my pleasure. Thank you. Bye.
Thank you.
is my slide is visible?
Yes,
Yes,
ma'am.
sir.
Okay. Good evening, everyone. My topic for today's discussion is troubleshooting in vaginal surgeries. As this topic is very much important for newcomers, but for senior consultant or doctors, it is not very much important. This is very basic thing which I am sharing. First thing is hysterectomy is the most common major gynecological surgery as we all know. And vaginal hysterectomy is preferred over abdominal hysterectomy. In today's era, laparoscopic hysterectomy is a suitable option of abdominal hysterectomy, but not an option of vaginal hysterectomy. Then, to avoid trouble, two things is important. First is perfect knowledge of pelvic anatomy. And the second is pelvic examination to assess size and mobility of the uterus, is stretching the cervix downward to know the acquired descent, as in, especially in cases of NDVH, and assessment of cornices and available space between cervix and lateral vaginal wall. What is troubleshooting in vaginal surgeries? Troubleshooting means early recognition of injuries, careful surgical planning, and tailored repair. So, vaginal surgery complications vary by procedures, and early identification prevents morbidity, and it requires strong anatomical knowledge. Troubleshooting, if we know if we recognize early injuries and we carefully plan the management of that troubleshooting, so it improves the outcome of the surgeries, and it is essential for safe surgical practices. What's the common intraoperative challenges? Common challenges are poor visualization due to bleeding, distorted anatomy from scarring, difficult access to operative fields, risk of bladder rectal injuries, need for adequate exposure, and prompt correction reduces the risk. Now, what is the various kind of trouble we all can see? No descent. For NTBH cases, uh, descent may not be present. Obliterated fornices, difficult bladder dissection, bleeding from bladder pillars and vesical plexus, obliterated cul-de-sac and adhesions in posterior fornix, inability to open posterior peritoneum, bleeding from posterior vaginal wall and vaginal angles, insecure pedicles, injury to bladder, injury to rectum, bleeding from uterine vessels, omental adhesions on uterus, obliterated utrovesical pouch of peritoneum, uterus adherent to anterior abdominal wall, large uterus or fibroid, which can cause difficult to deliver the uterus vaginally, bleeding from ovarian pedicles. Then coming to the common complication or troubleshooting things, we first is bladder injury. So how can we identify the bladder injury? It occurs during anterior wall dissection. Sudden urine leakage indicates bladder injury. We can use dye test if uncertain. अगर सामने दिख रहा है तो फिर it's okay. But if it is uncertain, then we can use dye test. Check bladder integrity before closure. Early recognition is very, very crucial. करना क्या है? What is the management of bladder injury? First is repair immediately in 2 layers. This is the anatomy of bladder. This is 3 layers. First is bladder mucosa, inward to outward, then bladder muscles and bladder serosa. First layer is simple continuous suturing comprising mucosa and muscularis. And second layer, simple continuous suturing comprising serosa. So repair immediately in 2 layers, ensure watertight closure, catheterization for 7 to 14 days, avoid tension on repair side, monitor complications, and Bert recommends cystoscopy post-operatively. This is the diagram showing 2 layers closure of bladder injury. Then coming to the hemorrhage during vaginal surgery. Venous plexus is common source for hemorrhage during vaginal surgery. So packing can help to control the bleeding. Identify arterial bleeders early. Exposure improves control and consider ligation techniques for ligation. Then coming next to the bowel injury, it is rare but serious complication. It occurs in posterior wall surgeries. Look for fecal contaminations. Rectal examination helps us to detect the degree of laceration, and repair is immediate. 2-layer closure preferred. Ensure tension-free repair. Administered antibiotics. Post-operative monitoring needed, and check for fistula formation. Then coming to the ureteric injury, it is very rare, mostly in procedentia, where ureteric anatomy is distorted. Risk increases with higher dissection. It may present with excess bleeding. Check ureteric jet post-operatively by cystoscope. Stenting often required. Delayed diagnosis worsen the outcome. Post-operative complications are, for post-operative complication, it requires proper post-op care. Infection is common due to flora. Hematoma may form. Retention or voiding difficulty may be there. Wound dehiscence is possible. Last but not the least, it is better to avoid trouble rather than inviting trouble. Training and development of skills are essential. Thank you so much.
Dr. Deepika, I request the chairpersons to please speak a few words about this session and give their valuable opinions about the tricks and troubleshooting in vaginal surgery. Chairpersons Dr. Sunita Jha Madam, Dr. Pratibha Rai Madam, and Dr. Meeta Sinha.
Am I audible?
Yes, ma'am.
Dr. Priyanka, very nice topic you have covered. So, yes, you have said that it is better to avoid trouble than to invite it. So, proper positioning, degree of prolapse, and proper investigation should be there. And at the time of surgery, the layering, when you will remove the bladder in correct layer, when you will open the pouch of Douglas nicely, then it is very rare to have any type of complication. So always be alert, always try to minimize the problem, and always be vigilant. And whenever you comes to a trouble, always call seniors to help you. And especially in procedencia, always do IVB to know the exact position of the ureter, and accordingly you have to treat it. And as the patient are very older, full of so many complications, so packing with glycerin, betadine to combat the infections are very important, and for correct layering is also nice. Never do vaginal hysterectomy in hurry. So I think when you will alert, the complication will be rare. Thank you.
Thank you, Priyanka.
Thank you, ma'am.
Very informative, well explained, and very impressive talk. Like a teaching professional of the AIMS Devghar, proud of you.
Thank you, ma'am. Thank you so much.
As we all know that it's a very long learning curve for the vaginal surgery. हमें अभी भी याद है इनिशियली प्रोलैप्स करके आते थे तो हमेशा डर लगा रहता था कभी भी जाके ओपन तो ना करना पड़े कोई ब्लीडर तो नहीं छूटा सो यू हैव एक्सप्लेन इन अ वेरी वेल वे सो थैंक यू सो मच एंड कॉन्ग्रेचुलेशन टू MC Patel sir starting this series again for the benefit of all delegates. We wish you all the best for the coming election. We are all with you.
Thank you, madam.
Dr. Meeta?
You have explained it very well, and as Pratima ma'am has said, correct layers should be identified, and then dissections should be done in correct layers. It was well explained. Thank you, Dr. Priyanka.
Thank you, ma'am. Thank you so much.
Thank you, Patel sir, for starting this again. Thank you, sir.
Thank you, Patel sir, for this opportunity. Thank you, sir.
We now move on to our second session. The second session is being chaired by some very eminent gynecologists of Jharkhand Obs and Gynae Society. The first, Dr. Aarti Shukla Madam, one of our dearest doctors from everybody in Bokaro is just in love with her. She's been the past president of Bokaro Obs and Gynae Society. She's always there for us. The CV does not really disclose anything about her. She has been there for every gynecologist in Bokaro, and that speaks words for her. She has organized state conferences. She has presented research papers, and been the past president of Bokaro Obs and Gynae Society. The next speaker is Dr. Manju. The next chairperson is Dr. Manju Bankar ma'am. Again, a very senior gynecologist from Deoghar Society, the ex-RSO from PMCH Patna, ex-registrar NMCH Patna, trained in hysteroscopy, honored for distinguished services and help to mankind, which is something very praiseworthy. She's another very senior gynecologist from Deoghar and a very lovable person. The next chairperson for this series is Dr. Sheshi Iyer from Jamshedpur. She's an ex-specialist from Tata Main Hospital, Jamshedpur, and presently consultant in SCRC Hospital, Jamshedpur. Another great academician. So this is going to be a feast for all of you, this session, which is going to be taken by Dr. Archana Kumari. Is Dr. Archana joined? Yeah. And
Yeah.
please, I would request the chairpersons to introduce her.
I
Aarti ma'am,
will introduce her.
yeah, please do.
Dr. Archana Kumari is MBBS, MS. First of all, thank you for giving me this opportunity. She is MBBS, MS, FICOG, ACME, professor and HOD of in charge, Department of Ops and Gynae. She is coordinator, co-convener MEU, member IRC, convener TWOP, master trainer
Yeah, madam, I'm chairperson of quiz committee Foxy. It is okay for me. And past secretary of
the
Ranchi
long
OBGYN Society. Recently, I conducted the conference and handed over the charge. At least now I am free from Ranchi OBGYN Society secretary's work.
We won't let
Thank
you
you,
get
madam,
free.
for your kind introduction. Can I start sharing my screen for the topic?
Yes.
So is my screen visible?
Not till now. Yes.
Make it
Visible,
full
no?
screen, please. Yeah, make it full screen, please.
Yeah, it is
Thank
full
you.
screen.
Yes, thank you.
I don't know where my screen went away. मेरे को कुछ नहीं दिख रहा अब.
हम लोग को दिख रहा है.
मेरे को अपना ही स्क्रीन नहीं दिख रहा है. Let me just check what has happened. Yes, it is visible here. And why it is not visible in my screen? Is there some problem with the view?
Could you switch it off and switch it on again, because your transcription has got on, and hence we are getting transcriptions below.
Okay, so
just switch it off. Just switch it off and switch it on again.
Switch it off.
Just stop sharing once. Stop sharing once.
Yeah, stop sharing. I will do.
Yeah, stop sharing.
Stop share. Okay. I will just stop share. Why it is not happening?
Yeah. Stop sharing ho gaya. Ab
Now
start
I
sharing
will
again.
share. Yeah.
Now you share. Dr. Archana, I might as well point out, has been really a last minute she's been a last minute change, but she's been very accommodative. And when I told her yesterday that Archana, please do this thing, because do this talk, because Dr. Komal is unfortunately indisposed. Yeah.
Is it visible now?
Yeah,
Yes.
it's visible now.
So, good evening, namaskar to everyone. First of all, I will start with expressing my gratitude to Dr. M C Patel, sir, for giving me this opportunity, although I'm a last moment entry, but I always enjoy delivering talks. And after a long time, I'm back to academics after this conference work, because when you organize a conference, you hardly have time to do academics. So thank you, Nivedita Di, for accommodating me at the last moment. My gratitude to the guest of honor for today, Chief Guest Dr. Das sir, and all the guests of honor for today, Dr. Ushana, Dr. Preeti Bala Sahai, and Dr. I am just forgetting who, but my regards to all the guests of
Dr.
honor.
S.K. Das, sir. Dr. S.K. Das, sir.
Dr. S.K. Das sir from Dhanbad, I know. And with gratitude to all the respected chairperson, I'll start my talk. The topic is classification and etiopathology of prolapse. This is a very important topic, of course, for undergraduate and postgraduate students, because they always are afraid of taking this topic during examination, or uterovaginal prolapse case nahi aaye to zyada acha hai. But I'll just try to simplify it and make you people understand in a better way. So the outline of my talk would be something like, after a brief introduction, I'll discuss about the supports of uterus, etiology and risk factor, classification of prolapse. There are different types and grades. And of course, the most confusing thing, which is actually, it is not confusing for us, but people are always, when they get in the exam, this case, they're always afraid of this POPQ classification. So I will just try to simplify it. So this is the definition. Pelvic organ prolapse is the descent or herniation of the pelvic organs through the urogenital diaphragm into or out of the vagina. I re-emphasize, into or out of the vagina, due to loss of the muscular and facial structural support, because it can be inside vagina also. Sometimes it will depend upon the grade. Of course, it is not life-threatening, but it does affect the quality of life. So we all know that pelvic organ prolapse is multifactorial in etiology, because the interaction between the pelvic floor muscle, the fibromuscular connective tissue, and intact innervation are key to maintain the pelvic support in their normal location. So actually, the pelvic organ prolapse results from either attenuation of the supportive structures, or by actual tear and breaks which occur during childbirth, or by neuromuscular dysfunction. The damage at different level of support will produce different type of prolapse, which I will be explaining in the subsequent slides. So this is very important to understand three levels of Delancey's three level of support. You can see in this diagram, there is a level 1 support, which is the suspensory axis. Level 2 is the attachment axis. And level 3 is the fusion axis. And the type of prolapse will depend upon which level is affected. So let us see it in the next slide. So here you can see the level 1 defect usually result in apical defect. Level 2 results in cystocele and rectocele, and level 3 results in the lowermost part. It affects the urethra and perineal body. So this actually slide will make it more clear. Level 1 support is the suspensory axis, which is related to the cervix and the upper vagina. And what are the supports here? These are the cardinal and uterosacral ligament. So if there is deficiency of these ligaments, then what will be the defect? It will be the uterine prolapse or the vault prolapse, or which we refer to as apical prolapse or enterocele. And what will be the symptom? It is usually asymptomatic. Patient may complain of bulge in the lower part. Level 2 attachment axis is related to the middle of the vagina. So what are the supports at this level? At the level of the middle vagina, anteriorly it is the pubocervical fascia, posteriorly it is the rectovaginal fossa, and laterally the paravaginal attachment of the lateral vagina and the endopelvic fossa to the ATFP, that is arcus tendinous fossa of the pelvis. And of course, the defect in these support will result either, if it occurs anteriorly, it will result in anterior vaginal wall prolapse. And if it occurs posteriorly, it will be the posterior vaginal wall prolapse. And of course, the defect at this level causes the maximum symptom. Of course, it will cause bulge in the lower part or something coming out. Then urinary symptom, the symptom related to defecation, manual digitation to actually do for the normal urination and defecation. Level 3 refers to the distal vagina, which is the fusion axis. So what are the supports at this level? It is anterior pubo urethral ligament, and posteriorly it is the perineal body. So the defect will result in the urethral hypermobility and the gaping introitus. And what will be the symptom? Of course, it will cause SUI, sexual dysfunction, vaginal dryness, and all these things. So after understanding the supports of the uterus, it is easy for us to understand the etiology. Childbirth trauma is the single most important factor because damage to the pelvic floor or endopelvic fossa occurs during this process. The genital hiatus widens, the ligaments are stretched or torn, and the pelvic organs sag to the wide hiatus. And of course, the increase in intra-abdominal pressure can result or aggravate the prolapse. These are the common etiological factor which we often ask from the UG student, and they have a ratto kind of thing. They are all set with these risk factors when the question is asked. These are multiparous women with short inter-pregnancy interval, prolonged second stage of labor, premature bearing down. This is very common when the delivery is conducted at home by untrained eyes. Then instrumental delivery, the big size baby, past surgery like hysterectomy, both abdominal and vaginal can predispose to vault prolapse, particularly when during vaginal hysterectomy, the enterocoel is not properly identified and repaired. It usually results in vault prolapse. And of course, after abdominal hysterectomy, it is very common when male surgeon does hysterectomy, they often overlook the presence of cystocele and rectocele. And of course, myopathy and neuropathy are could be one of the risk factor. Am I audible?
Yes, yes.
Oh, because there's pin drop silence, so I was just afraid whether my
No,
connection.
no, we are,
We are listening to you very patient.
Yeah, thank you so much for affirmation. So the congenital weakness could be one of the cause in nulliparous women. And there will be history of the inherent weakness of support in the members of the same family. There is some genetic factors like connective tissue disorder, Marfan syndrome or Ahler-Danner syndrome. These are very rare. To be very frank, in my career of 25 years, I have not seen these cases resulting in prolapse. But of course, for theory purpose, we do enumerate these causes. Patients with spina bifida are also prone to prolapse. The aggravating factors are, of course, menopause. We all know that after menopause, the uterovaginal prolapse is more common, and this happens because of the hypoestrogenism, and atrophy of the genital tract and its muscular and ligamentous support. Chronic cough, constipation, asthma, COPD, all these are things which we ask in history whenever a woman presents with uterovaginal prolapse. Of course, obesity, malnutrition, smoking could also be a risk factor or aggravating factor. And occupation like heavy weight lifter, manual labor, and heavy physical work are always the aggravating factors. Now, coming to the classification of pelvic organ prolapse, after discussing supports of uterus and the etiology part, let us come to this part. So what is there? Traditionally, we have classified prolapse by the degree of anatomical deformity, the site of defect, and also we have named them according to the presumed pelvic viscera that are involved with the descent of the uterovaginal uterus and vagina. But this traditional classification has lots of intra and inter-observable variability. And it is difficult to compare the successive examination even in the same patient, or of course, difficult to compare in the different patient. Different consultant will have different degrees. Like some will write mild cystocele, moderate cystocele, severe cystocele, or grade 3 cystocele. I mean, there is no number involved in these traditional classifications. So here we can see traditionally, we name these type of prolapse according to the presumed viscera which is behind the scene, like urethrocoele. It is prolapse of the lower 1/3 of the anterior vaginal wall. Cystocele, prolapse or descent of the upper 2/3 of the vaginal wall. It is named cystocele because it often carries bladder with it. And uterovaginal prolapse is actually the descent of both the uterus and vagina. Enterocele is prolapse of the upper 1/3 of the posterior vaginal wall. It is named so because it often contains loops of intestine and the bowel. Rectocele is a prolapse of lower posterior vaginal wall. Nowadays, it is middle 1/3 of the posterior vaginal wall, and it is named so because it carries rectum. But what is a disadvantage of traditional classification? There is always unrealistic certainty regarding the structure on the other side of the vaginal wall, a bulge. It could be a false assumption. Many a times, it is very difficult to differentiate between enterocele and rectocele. There are ways to differentiate, but just looking at the bulge, we cannot, we can presume what is the viscera behind it, and we name it accordingly. So the terms anterior vaginal wall prolapse, posterior vaginal wall prolapse, and apical prolapse are preferred term because of this uncertainty regarding the anatomical structure on the other side of the vaginal bulge. So anatomical classification would be anterior vaginal wall prolapse or anterior compartment defect, we can say, which will involve cystocele and erythrocele. That is the traditional way of classifying it. Apical vaginal wall prolapse, which is the middle compartment, it can be an introcele or it can be vaginal vault prolapse, of course, in post-hysterectomy cases, or it could be a uterovaginal prolapse. The posterior vaginal wall prolapse, that is the posterior compartment defect, will involve rectocele and perineal body defects. So enterocele actually belongs to the middle compartment or the apical compartment, we can say, but it can be a part of posterior compartment as well. So this is the traditional thing, which it is kind of revision to the previous slides of mine. Cystocele is descent of the upper 2/3 of the anterior vaginal wall along with the base of bladder. Erythrocele is descent of the lower 1/3 of the anterior vaginal wall along with urethral displacement. Cystoerythrocele is prolapse of the entire anterior vaginal wall. So can we grade cystocele? Yes, we can grade it as grade 1 when the bulge of the cystocele is inside the vagina on straining. Grade 2 when the bulge of the cystocele reaches up to the vulval outlet on straining. Grade 3 when the bulge of the cystocele is outside the vulval outlet. And grade 4 when bulge of the cystocele is seen outside the vulva all the time. And it is very important to differentiate between the central type of cystocele and the lateral type of cystocele. So central defect, how do we differentiate? In central type of cystocele, there will be loss of the vaginal rugosities because it results from the loss of the vaginal fascia. But the lateral sulcus is maintained. And in lateral type of cystocele, there is tear of the attachment of the vaginal fossa from the ATFP, arcus tendinous fossa or pelvis. So the lateral sulcus will be lost. But because there is no attenuation of the vaginal fascia, the rugosity in the anterior vaginal wall will be maintained. And this is actually the clinical thing which we usually ask to the postgraduate student during examination.
Dr. Archana, could you just explain this last thing again? This central defect and
The
lateral
difference
defect.
between the central and lateral type.
Yeah.
Actually, what happens when you look at the cystocele, you have to see whether the rugosities of the vaginal wall is preserved or not. If it is preserved, that means it has to be mostly lateral type, because the vaginal fascia between the underlying vaginal wall and the underlying thing, the fascia is attachment is not lost. So the rugosities will be there. But there is a lateral sulcus, which we usually see along the lower part of the pubic arch. So that lateral sulcus is where the vaginal fascia is attached to the paravaginal attachment occurs to the ATFP. So that attachment is lost, so that sulcus will not be there. On the contrary, in the central part, in the central type of cystocele, the lateral sulcus will be maintained, but the rugosities of the vagina will be lost. I think we can demonstrate you better in the live cases when actually we see the cases. I don't know how much I was able to explain it.
No, got it. No, got it.
Oh, thank you. And of course, the uterovaginal prolapse is the most common type because uterine prolapse is usually associated with either the anterior vaginal wall prolapse or posterior vaginal wall prolapse, or when it is, even if it is a straight uterine descent, it usually carries the vault with it. And this is the traditional posterior vaginal wall prolapse. Enterocele is prolapse or descent of the upper one-third of the posterior vaginal wall along with peritoneum and small bowel. Because it contains the peritoneal sac with it, it is actually the true hernia of all the pelvic floor disorders. So this question also we asked to the PG, which out of all the type of vaginal wall prolapse, which is the true hernia? It is actually the enterocele. So rectocele is prolapse of the middle one-third of the posterior vaginal wall along with rectum. And the lower one-third, deficiency of the lower one-third of the posterior vaginal wall results in gaping introitus. And this is because of the torn perineal body. So there are different other ways of classifying prolapse. Like this is the degree of the prolapse, not the types of the prolapse. So now we come to the degrees of prolapse. SOS, we all know, traditionally classifies it into 4 degrees. Baden has also got 4 grades, 0 to 4. BCAM has only 3 degrees. And of course, POPQ has 4 stages of uterovaginal wall prolapse. So let us see them one by one. SOS classification, normal, we know. The external loss of the cervix lies at the level of the ischial spine. So the cervix is at its normal anatomical position. There is no prolapse. So that is the normal or 0 degree. First degree, what happens? Cervix descends below the ischial spine, but it is still above the introitus. Second degree, the cervix lies at the introitus, but does not come out up to the introitus. Third degree, cervix descend out of the introitus, but not the whole of the uterine body is outside. Fourth degree, as we all know, procedentia is the descent of the whole of the uterus outside the vagina. And clinically, of course, we know how to differentiate procedentia from third degree. If we approximate our fingers, thumb anteriorly and 4 fingers posteriorly, we can get above the fundus, it is procedentia. If you are not able to get above the fundus, it is third degree. So BCAM classification actually is only 3 degrees. First degree, cervix and body of the uterus descend from the normal position but lies within the vagina. Second degree, cervix outside the introitus, but body, it is like third degree of the SOS classification or SOS degrees of prolapse. Third degree is complete eversion of the uterus and whole of the uterus is outside the introitus. Batten-Walker half-face system is another very common system after POPQ classification, which has come into in recent years. So grade 0 is normal position. Grade 1 is descent of the vaginal walls halfway to the hymen. Grade 2 is descent up to the hymen. Grade 3 is descent halfway after the hymen. And grade 4 is maximum possible descent for each side. So it is better seen in this diagram. You can see this is grade 1 halfway to the hymen, grade 2 up to the hymen, grade 3 halfway past the hymen, and this is the maximum descent. This is little complicated, so I'm going to skip this slide. And now we come to the POPQ classification, that is pelvic organ prolapse quantification system, which was started by Bum et al. In 1996, and it has been recommended by international bodies like ACOG and International Continence Society as well. So remember, it measures 9 distances, out of which there are 6 vaginal points. There are 6 vaginal points, A, B, A, P, BP. These are in the posterior vaginal wall. C, D are the other vaginal points. And there are 3 lengths. Genital hiatus is GH, perineal body, and TVL, total vaginal length. So these are 3 distance and 6 vaginal points. But remember, the reference point for all measurement in POPQ classification is hymenal ring. It is not the introitus. So this reference point can make different system overlap a little bit. That I will make you understand in a few next slides. So this is actually a complicated slide, but I will try to explain it. You just try to understand there are 2 points in the anterior vaginal wall, AA and BA. So what is AA? It is fixed point, which we measure. It is actually 3 centimeter proximal to the hymen in the anterior vaginal wall in the middle. And why we select this 3 centimeter? Because this is the uretero it is a junction of the urethra and the bladder. And of course, if there is descent of the anterior vaginal wall, this AA can vary from something from -3, which is a normal, it is a normal, and it can go maximum up to this point, can go up to +3 centimeters. So -3 to +3. What is BA? BA, I will make you understand in the next, actually this diagram better understands it. This was AA. This is 3 centimeter proximal to the hymen. Now what is BA? This is actually BA point. This is most distal portion of the remaining upper part of the anterior vaginal wall. This is very important to understand what is BA. It is most distal portion of the remaining upper part, matlab excluding the first 3 centimeter or lower 3 centimeter of the anterior vaginal wall. So, and then coming to C, what is C? It is most distal edge of the cervix. And of course, when the patient is hysterectomized, there can be no cervix. So in that case, we take the vaginal cuff. And let us first discuss what can be the extent of BA. It can vary from -3. -3 is the normal thing when there is no defect in the anterior vaginal wall. So in that condition, both AA and BA point will be the same. But BA can vary from -3 to plus TVL. TVL is the total vaginal length. C can vary, of course, from plus to minus TVL. If it is normal, usually C, the cervix lies, we take the total vaginal length from the hymen to the cervix. So it will lie at the length of the, whatever is the total length of the vagina when there is no prolapse. And plus and minus is actually with reference to the hymen. Whatever measurements are taken above the hymen is minus, and whatever is below the hymen is plus. So the normal C position will be minus TVL, -8 centimeter. The normal length of the vagina could vary from 8 to 11 centimeter, 12 centimeter. So C will be, can vary from plus to minus TVL. What is D? D actually denotes the location of the posterior fornix, the pouch of Douglas. And it is actually the attachment of the uterosacral ligament. So, and of course, D point is not measured in hysterectomized patient. And D is usually 2 centimeter proximal to the C. So you can see C is this thing, and D is the pouch of Douglas. We all know that posterior fornix or the lowermost part of the reflection of the rectovaginal pouch, this is usually 2 centimeter above the cervix. So it is minus, it is 2 centimeter proximal to C. AP is again similarly, as we discussed in the anterior vaginal wall, similarly in the posterior vaginal wall, AP is a fixed point which is 3 centimeter proximal to the hymen. And BP is again the most distal part. This is AP, fixed point, 3 centimeter proximal to the hymen. BP is this point, which is the most distal portion of the remaining upper part of the posterior vaginal wall. So when there is no prolapse, of course, AP and BP will be the same. And then, so we are done with the 6 vaginal points. Now the 3 measurements. TVL is the greatest depth of the vagina. We measure it when we reduce the prolapse, and the C and D, the cervix and pouch of Douglas, cervix is in the normal anatomical position. So it varies from 10 to 11 centimeter. GH is the distance from midpoint of the external urethral meatus to the posterior fourchette, and perineal body is from posterior fourchette to the midpoint of the anus. And so you can see the genitally hiatus's normal condition is less than the perineal body measurement. But when there is defect of the posterior vaginal wall, gaping introitus, this will be reversed. So we usually make a grid for measuring these 9 points, 6 vaginal points and the 3 distances. We make grid like this, AA, BA, C. And in the middle portion, we mark GH, perineal body, TVL, and here in the last column, last row rather, we measure AP, BP, and D. So depending upon these points, we stage POPQ classification into 4 stages. So how they go? Stage 0, no descent of the pelvic organ prolapse. Stage 1 is most distal or leading portion of the prolapse is more than 1 centimeter above the level of the hymen. And stage 2, most distal portion of the prolapse is within 1 centimeter proximal or distal to the plane of the hymen. Stage 3, when the most distal portion of the prolapse is more than 1 centimeter distal to the hymen, but it is less than TVL minus 2. That is, if TVL is 10, it is less than 8 centimeter. I will make you understand in a better way because I have pictures to show you about these stages. So stage 4, what happens? Complete to nearly complete eversion of the vagina. And this is actually the most distal portion of the prolapse produced beyond TVL minus 2. So this is the picture where you can understand what is stage 1 POPQ classification. So you can see the most distal portion of the prolapse is 1 centimeter above the hymen, right? So this is stage 1. So what is stage 2? The most distal portion of the prolapse part is between 1 centimeter proximal to the hymen and 1 centimeter distal to the hymen. So whenever the most distal part will lie in this area, it will be a stage 2 POPQ classification of prolapse. Stage 3 is here you can see. So this is the blue portion where is the stage 2 prolapse. So now you can see in stage 3 what happens. The most distal portion of the prolapse part is beyond 1 centimeter of the hymen, but it is less than TVL minus 2. It is still not gone. It is not complete.
Archana has probably lost her network.
There must be some technical issues. Because we can see the pictures.
Yeah. Just a moment, I'll call her. She just lost network, so she's coming back on.
In between, we can take the input from the chairpersons.
Yeah. जब तक अर्चना वापस आती है, प्रतिभा मैम, आरती मैम, आप लोग कुछ बोलना चाहिएगा। एंड नहीं, ये नहीं है। हाँ, आरती मैम, प्रतिभा मैम नहीं है, आरती मैम है, शशि हाँ, शशि अय्यर मैम है, एंड हेलो,
माया मैम है।
हाँ हाँ, आरती मैम आप कुछ बोलना चाहिएगा? शशि मैम इज देयर।
मेरे को तो लगा कि मैं मेडिकल कॉलेज की पीजी स्टूडेंट हूँ। इतना अच्छा ऑलमोस्ट ऐसा लेक्चर लग रहा था। शी इज अ प्रोफेसर एंड शी स्पोक लाइक अ प्रोफेसर एंड हर स्लाइड्स वेर वेरी गुड। बहुत अच्छा एक्सप्लेन किया उन्होंने।
इज डॉक्टर मंजू बानकर मैम हियर? डॉक्टर मंजू बानकर मैम है? हाँ, यस मैम, यस मैम।
My input is it was thoroughly complete by Dr.
Archana.
And as she said कि हम लोग तो फिर से लगता है मेडिकल कॉलेज में चले गए and sitting on the benches and listening to my professor. Very clear, very good, and everything is, cleared up very easily, and it was so clear that you don't need any description beyond this. When I salute to Dr. Archana, she has really done a very good job. और students लोग के लिए तो बहुत अच्छा है. This paper can be presented to the students and very useful for teaching.
I was just thinking, hopefully the PGs have joined because this was like just really मतलब बच्चों के मतलब PGs के लिए बहुत
बिल्कुल
अच्छा
बिल्कुल
हाँ
बिल्कुल एक मैंने बच्चों को पढ़ा रहे हैं ऐसा लग रहा था
तो एक्चुअली पढ़ाती तो है ना इसीलिए
Because
हाँ
when
वो
we
प्रोफेसर
we are into our clinical practice, we don't give much importance to these
No,
all things. We
after
just give
passing
more
out
importance
and
on the practical management.
after passing out and coming into the this practice, we don't even see so much staging of a prolapse and what not. So my God, it's very very
Rita, can you
difficult.
talk to Dr. Archana? This is on phone.
I spoke to
Otherwise,
her.
it will be very delayed. Will be delayed.
POP classification is the recent classification for better understanding, and Dr. Archana described it very nicely, mind-blowing presentation.
Mind blowing.
Congratulations, Archana, for your this presentation.
Archana is not here to listen. So when she comes, we'll again have to tell
तो
her.
मैं तब तक हम प्रोसीड करते हैं जब तुम आओगे तो
हाँ
फिर लास्ट हम लोग ज्वाइन करवा लेंगे
हाँ हाँ
ठीक है ठीक 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 ठीक
मुझे
ठीक
लगता है
ठीक
कि we can go
ओके
to Dr. Patel's.
हाँ Archana said that she has some issues so she says if possible if she has network then she'll start again but it was really awesome and on a personal level I feel that sometimes when we understage like for example as Archana rightfully said हम लोगों ने उसको cystocele rectocele कहा and we've missed out on enterocele then the patient has a very high chance of coming back with a wall prolapse so it is very important to stage
Yes.
correctly
Always you should correct enterocele whenever you repair.
Dr. Nivedita,
Whenever you
please
do
ask Dr.
mastectomy.
Archana to post the presentation on the forum
I'll tell her
so that
मैं
we can
फोटो
go
से
it
डाल रही
again and again.
मैं फोटो से डाल रही थी but
Then you
anyway
can
now
start.
I hand over the session I with these
Nivedita ma'am,
words
I'm there. Yes, ma'am.
okay yeah Dr. Monica yeah
Let us start with the third talk, which is by Dr. M C Patel sir himself, and he will be speaking about the rising rate of hysterectomy, the legal, ethical, social, and medical perspectives of the same. For this session, we have our esteemed chairpersons, Dr. Shivani Jha madam, Dr. Shashibala ma'am, Dr. Subhadra Malik, and Dr. Arpita Gandhi. Can we have those CV slides, please? Dr. Shivani Jha madam is the past president of the Dhanbad OBGY Society, a senior consultant. The next slide, please. Dr. Shashibala Singh madam is the president of the Ranchi OBGY Society. She's been the president of ISOBAB of the Ranchi chapter, the vice president of the Ranchi OBGY Society from 17 to 19. She's also been the organizing secretary of the Ranchi annual conference from 16 to 17, the head of the department of OBGY at RIMS Ranchi. We welcome you, ma'am. Our next chairperson is Dr. Subhadra Malik, madam. She has more than 32 years of experience with different posts in the last 7 years. She has been the visiting consultant at Abhishek Maternal and Child Health Hospital at JSR and as faculty at Sri Satya Sai Sanjeevani Hospital. She has been the past vice president and past secretary of JS. She is currently the executive member. We welcome you, ma'am. And Dr. Arpita Gandhi, madam, is a founder president of the Devgar OBGY Society. She's also a member of the Safe Motherhood Committee and she's received the Best Doctors Award from Bharat Vikas Parishad Jharkhand Bengal Samiti, Lions Club of Devgar. Her special interests include ectopic scar pregnancies and secondary PPH. We welcome you, ma'am. I request our chairpersons to please introduce our speaker, Dr. M C Patel, sir. Arpita, ma'am, please.
Good evening. I thank the organizers for giving me this opportunity to introduce the so-called Suraj ko diya dikhana, and sir is very favorite of all the Jharkhandis, and this time I'm not going to introduce him in this webinar because everyone knows who is sir. But this time I promise you, sir, that each and every vote of Jharkhand will go for you. And
Thank you.
I especially me, me and my society, Priyanka, Manjudi, Rita, Divya, we all will pray for you also to Lord Vaidyanath that this time you will win by a large margin.
Thank you.
So I invite you, sir, to deliver your important lecture.
Yes. So let me share my screen. Is it seen? Full screen?
Yes, sir.
Yes.
Yes, sir.
So greetings from Statue of Unity, tallest statue of world. We all are proud of that statue. Warm welcome all the delegates and wishing you a litigation-free practice. At the outset, I would like to thank all the Society of Jharkhand who have joined this webinar, Bokaro, Jamshedpur, Dhanbad, Devghar and Ranchi, and President and Secretary of respective society, and all the delegates, all the faculty. I again thank you everybody for everything you did during my last election. Though I lost, but I believe in this. This is very nicely written by Shraddhe Atal Bihari Bajpayee, and I was lucky to work under him for some time. He wrote very nicely, क्या हार में क्या जीत में किंचित नहीं भयभीत में कर्तव्य के पथ पर जो भी मिला ये भी सही वो भी सही. So loss is not the end, but a new beginning. Journey to serve Foxy continued with renewed patience, and my commitment is still there. Wherever you are, I will be there. Promise to reach the unreached. So I'll be seeking same blessing, same support, same help, same guidance for next year 2026 election year and for the same post President Foxy. So thank you for the same. So today's topic hysterectomy, particularly in less than 40 years of age, legal, and it's a matter of concern for us because we being a gynecologist are directly concerned to that, and rising rates of hysterectomy there has their own perspectives, legal, ethical, social and medical. Usually I start any of my talk with this question: is it worth discussing? Yes. And if it is yes, then why? Because let us hear the story of so many patients and ultimately what government has taken step and what government is going to be strict in future. Let us hear the story of Sunita, 25 years old woman from small village of Rajasthan. I went to clinic because I had heavy bleeding during menstruation. Doctor did an ultrasound and said I might develop cancer. He rushed me into having a hysterectomy the same day. I was reluctant to have operation straight away and wanted to discuss it with my husband first. But doctor said operation was urgent and sent me for surgery just hours later. Sunita says she still feels too weak to work or look after her children. So this type of story we have to listen carefully. And let us see story from Vandana. Vandana is still 30 years and has not contributed much to the family income in past 6 years. Her husband is a daily wage laborer and now she stole breadwinner of his 5 members family. 6 years ago, when she was 24, extreme pain in lower abdomen and bleeding made working on agriculture field a struggle. It was worse during her period. On days she missed work, contractor would deduct her salary because in that very area, contractor is not willing to allow person who is having menstruation in those days, and they do not allow for field work. So local doctors gave her some pills, but that gave only temporary pain relief. So to get rid of persistent problem, she visited a private hospital. Here, doctor suggested to get rid of uterus altogether and cause for all her troubles. So she was hysterectomized, and she said like this: "They stole my womb. Doctors midlist thousands of women to get their uterus removed." Let us see the same patient, Vandana. Vandana thought this was the best solution to her problem, and she had to sell out rupees 4,000 for it. Complain after hysterectomy. Sorry. I have developed severe joint pain and feels tired all the time. I get irritated far too often, and working on fields has become difficult. She is among thousands of young women across country who opt for hysterectomy earlier. So this is the story. Let us see one more story from Saya. What Saya has to say. 30 years of Sayadok says she hardly has any strength to work on sugarcane field. She got her uterus removed on a doctor's advice at the age of 19. At the age of 19, her uterus was removed. I would suffer from abdominal pain after laboring on the field. He asked me to undergo procedure and said I have a tumor that may convert into cancer, and she was married at the age of 12, and by this age of 19, just after 7 years of marriage, she had already 4 children, so she agreed to remove uterus at age of 19. So many health organizations came together to demand an inquiry into illegal hysterectomy of women laborers in Bid district, which is in Maharashtra, known for sugarcane farming. So now one more story of sugarcane field worker. In Bid district of Maharashtra, female workers are not allowed in field during menstrual period, and female workers opt the option of hysterectomy as soon as they complete the family, irrespective of her age. So many health organizations came together to demand an inquiry into alleged illegal hysterectomy of women laborers in Bid district, known for sugarcane farming. And according to data from National Family Health Survey, this figure is a sharp contrast of rate of hysterectomy conducted in Maharashtra, which stands at 2.6%. Usually rate is 2.6% in Maharashtra. It is also much higher than rate across India, which is 3%. But in this district, in 2018, out of 200 women surveyed in Bid district, 72 had undergone a hysterectomy. So almost 36% was the rate of hysterectomy in that very district. In 2019, out of 271 surveyed, 56 had undergone the procedure. So according to health worker, many private doctors insist the fear of cancer and convince villagers to go for hysterectomy. This is outcome from the survey in that very district. We found that 11 private hospitals regularly conduct hysterectomy in Bid, and state government must investigate whether each case required the surgery or was conducted without medical reason. So this type of allegation was there. He added that they had submitted a charter of demands to health and women and child development departments in that very district. So at least 85% hysterectomy in Bid district are conducted in private hospital. It was observation during that survey. So study from Maharashtra, India revealed that problem is much deep-rooted, as hysterectomy have become a norm in district where sugarcane cutting contractors are unwilling to hire menstruating women, leading to warmless villages. And the issue highlights the fact that women are compelled to earn and care for their families. Hence, they balance their medical options with social responsibility. So, encouraging hysterectomy in rural India was the matter of concern, and particularly at the age less than 40 years. And in this report from handful in Indian state including Rajasthan, Bihar, Chhattisgarh and Andhra Pradesh suggest that an extraordinarily high number of women are having their uterus removed, including many below the age of 40. So, to ease the burden on rural poor, the Indian government launched a national health insurance scheme that is in 2008, and this scheme was misused in certain area. Under the scheme, families living below poverty line can receive treatment worth of rupees 30,000 rupees each year from designated private hospital which claim the cost directly from the state. So in this situation, if expense is less than 30,000, then patient had to pay nothing and hospital will claim from government directly. But in some states, the scheme appears to be encouraging unnecessary hysterectomy. It was found in one of the survey. And unethical private clinics exploit vulnerable poor using them tap into government funds. And failing public health system and preferential choice of private hospital over public hospital might be the reason for increasing number of hysterectomy in the country. So insurance and unindicated hysterectomy was the observation during that very survey. Many Indian states have recently introduced insurance scheme, just I mentioned, so not to repeat, but researchers at IIT Delhi use National Family Health Survey data to show a positive association between hysterectomy rates and access to cashless state health insurance, notably in state of Andhra Pradesh and Telangana. In Andhra Pradesh state government's Rajiv Arogyasri health insurance program launched in 2007 reimbursed both public and private hospital, and Arogyasri provided generous cashless coverage for tertiary health care to 19.2 million below poverty line, thousands paying higher rates to hospital than other comparable program. So hysterectomies in younger Indian women. So this data show influence on health insurance subsidies. The New Indian Express was the newspaper to publish this. So what do the statistics say? In 2015 to 16, fourth National Family Health Survey, a cross-sectional survey conducted direct information on hysterectomy and self-reported region. So women between 30 and 49 undergo hysterectomy in state or union territory. So percentage were like this. National level 6%, Andhra Pradesh 16%, Telangana 14%, Bihar 11%, Gujarat 8%, and Tamil Nadu 6%. So 36% underwent hysterectomy below age of 40 years and median age was 34 years in that very survey. 67.3% in private health sector and 32.3% in public health sector. But very interesting relation between tubal ligation and hysterectomy was found that sizable proportion of women underwent sterilization at younger age, less than 25 years. In high hysterectomy prevalence state, it was found in Karnataka 58%, Andhra Pradesh 39%, and Telangana 26%. It was correlation between this tubectomy before 25 years and hysterectomy occurred in this very state. So approximately two-thirds of hysterectomies were conducted in private hospital. It was under survey. So all states and union territory had the same pattern except Northeast state, Himachal Pradesh, Odisha, Chandigarh and Puducherry where use of public facilities were more. Rather than considering into private, they preferred in a public facility. So hysterectomy is one of the most frequently performed surgery or surgical procedure during reproductive age in many countries worldwide after cesarean section. We all know this. So are they really or scientifically indicated is a question nowadays with these examples of bid district and Andhra Pradesh and Telangana. So factors for unnecessary hysterectomy among rural and poor women, as fear instigated by medical professional was the one of the reason came in this survey. A solution for menstrual problems and related to taboos, failure of appropriate gynecological care, practical difficulties in living with reproductive health problems, believe that hysterectomy is the best treatment, and inappropriate use of insurance scheme. So particularly in Bihar and UP, Andhra Pradesh and Telangana, it was found. So feeding employment opportunity found in bid district of Maharashtra. So hysterectomy by different states and region of India for women aged 15 to 49 years of age, the prevalence of hysterectomy operation in India was, sorry. So prevalence of hysterectomy operation in India was 3.2%. In rural India, it was 3.4%. Urban India, 2.7%. But if you go like this, South India, 5%. East India, 3.3%. West India, 3.1%. And Central India 2.4%, North India 2.1%. So rural India had higher prevalence than urban India. It was observation during this survey, and majority of women underwent operation in private hospital. It was the observation. So, and one very interesting study came from Andhra Pradesh. Nearly 60% of hysterectomy were conducted on age below 30 years. 95% of them perform in private hospital, and discharge summary of these operations were incomplete and with no information of procedure or follow-up advice. So common causes as far as hysterectomy were concerned during this survey was found: excessive menstrual bleeding in 45.8%, fibroid or cyst in 17.6%, uterine disorders 12.7%, uterine prolapse 7.6%, and other causes 16.2%. So with this survey, very important question raised: is there any way ahead to deal with this problem? So sugar paint field worker story in district bid. Is there any role of sugarcane field worker? Can we convince them to allow uh, women during menstrual period as far as their field work is concerned? Role of doctor, naturally very important role as far as doctor fraternity is concerned, not to scare patient of malignancy or so, and they should be
इंजेक्शन लगा दो
meticulously
ना,
advised
आईवी
for
ड्रिप चलिए
another
रहा है,
alternative also. So
आईवी
proper
दे दो,
counseling, when many time patient is also willing to go
और
for
ये क्या कहते
hysterectomy
हैं,
treatment,
बोल देना कि एकदम
there are
संभल
some
सी
other
जाएगी
things
और एक
also
दिन बीच कर
we have
करके
to
गैस
counsel
लोग
them
पिएगी,
properly. Can they be discouraged as far as option of
हमारी
hysterectomy is
अपनी
concerned
चलवा
if it
जाएगी,
is selected on part of patient?
ठीक है ना,
Naturally, yes. So we have to go with, and naturally it involves ethical, moral, legal, and social issues. So what is the way beyond? So government came with by Health and Family Welfare Department on 28th April 2023, and manual came, guidelines to prevent unnecessary hysterectomy, and it was observed during this manual release. Field-based report have also suggested that there are unnecessary hysterectomy performed in cases where medical and non-invasive treatment would have been sufficient. And there are also reports of potential concern for financial benefit under health scheme, insurance scheme, and concern pertaining to lack of information provided to women on side effects. So naturally, way beyond, and community awareness. So in this government manual, it is mentioned that community awareness. So removing myths and misconception in the people in that very community, avoiding unnecessary hysterectomy, campaigning for preventing unnecessary hysterectomy, and existing agency that can help build awareness in community which are working in field in rural area. So village health sanitation and nutrition committee, women's self-help group, Mahila Arogya Samiti. There are so many Samiti. I do not want to go into detail, but all this Samiti can be taken into consideration and they can be trained to have a community awareness and not to end up into hysterectomy at early age. So monitoring and evaluation, government has come up with this also. So reporting of hysterectomy may be compulsory in future if rate of hysterectomy will be increasing day by day. So number of hysterectomy cases conducted, particularly in less than 40 years of age. What was the cause of hysterectomy? And it will also be considered. And it will be cause of hysterectomy need to be incorporated in existing non-communicable disease screening checklist. Data pertaining to hysterectomy must be regularly monitored at both state and district level. So there will be monitoring from public and private sector both, and government institution, medical professional from both public and private sector as well as other stakeholder must come together to make this monitoring successful. So there will be three-tier system in government as far as screening is concerned. District Hysterectomy Monitoring Committee under chairperson of District CMO and NCD nodal and all other officers also. And they will issue necessary orders to both public and private sector to submit a line list of all women who underwent hysterectomy every month. So what was the age of patient? What was the parity, occupation, indication of hysterectomy, previous medical or surgical history, route of hysterectomy, abdominal, vaginal, laparoscopy, any other surgery done along with hysterectomy, past treatment history, and histopathological examination will also have to be submitted. And every quarterly, they will have a audit meeting as far as indication of hysterectomy is concerned, and particularly below age of 40 years. All cases where no records of treatment prior to hysterectomy will be taken into consideration seriously, and discrepancy between mentioned indication and histopathological report will also taken into consideration, and any severe morbidity or mortality due to hysterectomy will also be taken into consideration. And same way there will be state monitoring committee also. They will have 6 months meeting and they will review report from district authority. And same way there will be national committee to review report from different state, and they will have 6 months meeting in that very uh, uh, issue. And in this very manual, government has come up with all the guideline. How will you manage cases of different indications and not to straightway jump into hysterectomy? Say for example, AUB or DUB. So first, government has advised to go with medical treatment, tranexamic acid, non-steroidal anti-inflammatory drugs, combined oral contraceptive pills, progesterone or denazole, levonorgestrel releasing intrauterine device, and surgical treatment for dysfunctional uterine bleeding, but not hysterectomy. Conservative surgery should be preferred. Endometrial ablation, first generation endometrial ablation technique, hysteroscopy, laser ablation, transcervical endometrial resection, rollerball endometrial ablation, second generation endometrial ablation technique. So all the lists are given in that very manual. Thermal balloon endometrial ablation, and endometrial ablation by hysteroscopic installation of hot saline is also mentioned in that very list. Surgical treatment for dysfunctional uterine bleeding, they have mentioned microwave endometrial ablation, endometrial laser intrauterine thermal therapy, cryoendometrial ablation, bipolar impedance control endometrial ablation. So for AUB and DUB, long list of treatment is suggested before jumping towards the hysterectomy. Uterovaginal prolapse, in that very manual, different sling operations are mentioned, and they have insist to prefer this rather than to go for hysterectomy. Sirodkar sling, Purandare sling, Khanna sling, Sonawala sling, Joshi, Virkud, and all other methods to deal with prolapse rather than to go for hysterectomy. Precancerous lesion of cervix and unhealthy cervix, medical treatment is also suggested. And when there is no infection, conduct the following test. It is also suggested: VIA, Willi, Pap smear, HPV testing, and treatment of CIN on histopathological or biopsy specimen. So before going to go for straightway hysterectomy, all this should be tried, is mentioned in that very manual. Vaginal discharge, lower abdominal pill. So these are the common indication as far as hysterectomy is concerned, and government has come up with all guidelines in that very manual how to deal with in those very respective cases. So not to end up into any problem in future from government side or from patient side as far as litigation part is concerned. Then how to prevent? Well, let us see, this is real happen case. XYZ P3, 53 years, menopause since 12 years, post-menopausal bleeding for 15 days. USG shows multiple small to moderate size fibroid, small cyst of 3.5 centimeter in right ovary, came for hysterectomy. So here there were few questions whether hysterectomy, yes or no. Only a total abdominal hysterectomy with bilateral salpingo-oophorectomy or unilateral salpingo-oophorectomy. Counseling for uterus removal must, and ovaries removed must, and separate consent for bilateral salpingo-oophorectomy, yes or no. In this particular case, without doing this proper counseling, hysterectomy was done. Patient recovered well. Patient was discharged in due course. But for any reason, she filed complaint against gynecologist after 2 months. Her question was why hysterectomy was done, why oophorectomy was done, why only cystectomy was not done. So in this particular case, what could have been done to avoid litigation in this type of situation? So in this famous case of C. Jaipal Reddy versus Padmini Veluri, National Commission has very specifically mentioned that consent is not mere piece of paper where patient has to sign, but it is a very important document of your counseling, of your communication to the patient, and you will explain each and everything at the time of counseling and taking consent about procedure or surgery you are offering. So as far as hysterectomy is concerned, we will have to explain everything to the patient. And once you explain everything and once patient signs the document, it becomes documentation of your communication. So you have to visit Foxy website, and in Foxy website, under title Foxy's Uniform Consent, with 3 medical legal experts, we have prepared 30 different consent. Dr. Dilip Walke from Pune, Dr. Nikhil Dadar from Mumbai, and myself, Dr. MC Patel from Ahmedabad. We have prepared 30 different consent. And let us see as far as hysterectomy part is concerned. So we have prepared consent in 2 parts, and we have taken famous case as a base, Samira Kohli versus Prabha Manchanda. So part 1 is information about surgery. Say for example, name of procedure, meaning, indication, description of procedure, benefit of procedure, alternative, consequences of refusal of procedure, outline substantial risks, risk related to anesthesia, possibility of excessive bleeding, blood accumulation, infection, injury to surrounding structure. Every individual has a different way to cope up. We have mentioned that also. Rare condition like allergic reaction to drug. And so just like say for example, name of procedure, open or abdominal hysterectomy, or if we have preferred vaginal, then we have to mention vaginal hysterectomy. If endoscopy, then endoscopic hysterectomy. whether we are going to go for salpingectomy, right, left, or both, ovarian cystectomy, right, left, or both, oophorectomy, right, left, or both. So we have to mention and we have to take consent for the that very also. If you have taken consent for hysterectomy, we cannot remove tube or ovary if we have not taken consent for the same particularly. Meaning, what is the meaning of hysterectomy? We have mentioned in a very simple language, surgical removal of uterus is called hysterectomy. Uterus along with its lower part cervix is removed in this case. If fallopian tube is to be removed, we have mentioned that. If oophorectomy is done, then also we have mentioned. If with hysterectomy, ovarian cyst is to be removed and no this oophorectomy, we have mentioned that also. Indication, we have mentioned all the indication, but if you have more indication, you can add at the end of this list. Description of procedure, how abdominal hysterectomy is done, how vaginal hysterectomy is done, how endoscopic hysterectomy is done. We have given separate consent for all this route of surgery. Benefit of procedure. What is the benefit of hysterectomy? That also we have mentioned. Effect of removal of ovary. If you are going to remove ovary, then what could be the effect of removal of ovary? What could be positive effect? What could be negative effect? We have mentioned that also. Effect of removal of cyst of ovary. With hysterectomy, if we have preserved ovary, but we have to go for removal of cyst, then we have to mention that also. Removal of fallopian tube. Now it has become almost common to go with bilateral salpingectomy with hysterectomy, not to end up into malignancy in future. So we have mentioned that also. Protection from possibility of ovarian cancer in future. So at the time of taking consent, we have mentioned that also. Alternative, are there any medical therapy to offer and not hysterectomy? If hysterectomy, if medical therapy is failed, and if we have to go for surgical procedure, then is hysterectomy is the only alternative, or can we go with some other surgical measures also? So we have to explain all the alternative to the patient, and patient is free to choose any one of them. Of course, we can explain patient which is best for her in that very given situation, but we have to offer all the alternative to the patient in that very situation. So abdominal surgery is conventional surgery, we have mentioned that also. One more area, consequences of refusal of procedure. If patient is not willing to give consent for hysterectomy, and if it is really indicated, then we have to explain patient which are the consequences of refusal of procedure. And even then patient is not willing, then you cannot force to go for hysterectomy. Outline substantial risk. So risk related to possibility of excessive bleeding or blood accumulation, possibility of infection, injury to surrounding structure like urinary bladder, ureter, bowel, or blood vessels, possibility of infection, and uh, 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 risk related to anesthesia also we have mentioned. Every individual has a different way to cope up, and we have mentioned that in case of abdominal hysterectomy, there could be possibility of hernia formation in that very situation, or she may develop adhesion with bowel or other internal structure, and she may end up into prolapse in future also. So we have mentioned all these in that very situation. Very rare condition, allergic reaction to any drug, we have also mentioned. Part 2 is undertaking. So whatever we have mentioned in part 1, that is information related to that very procedure or surgery, patient will go with undertaking in part 2. But this is very important part which is mentioned here in red color. If patient can give a consent like this, if any unanticipated or unhealthy condition occurs, and if doctor has to go beyond the scope of consent given by me, I give authority to Mr. or Mrs. So and so waiting outside operation theater to discuss with them, and if they give consent, then doctor can proceed beyond the scope of consent given by me. And we have mentioned like this also, if patient give consent like this, that in order to save life, it may even be necessary to do additional surgery or procedure and prolonged anesthesia, which are beyond the scope of consent given by me. I authorize doctor to take such decision if need be. So if patient has given consent like this, then no need to discuss with relative also, and you can go beyond the scope of consent given by patient. At the end of consent, signature of thumb impression and two witnesses, one in favor of hospital, one in favor of a patient, and signature of doctor should also be there in consent paper. So rising hysterectomy is a matter of concern. Proper counseling to the patient is very much must, and if it is not really indicated, we have to discourage patient as far as decision of hysterectomy is concerned. So discourage on-demand hysterectomy is a motto nowadays, and government also insists for the same. So judicial decision on part of doctor whether to go for hysterectomy or whether to offer other alternative to the patient, and not to end up into litigation after hysterectomy in younger age. If you want to sleep like this, take tender care of your patient, pray Almighty God before going to sleep, and stick to the guideline given by government in that manual, and keep my visiting card below your pillow. So all the best with regards. Salute to all. Thank you. Thank you very much. Please do not assume. Please ask if any query, any questions, if chairpersons and time permits. Thank you. Thank you very much.
Thank you, sir, for an elaborate talk. I request all the chairpersons to please give their remarks. Arpita ma'am.
अर्पिता दी अनम्यूट करून हाँ ठीक है
Hello, am I audible?
Yes,
Yes,
ma'am.
ma'am.
Hello,
Yes, you are audible, madam.
am I audible?
Yes,
Yes,
you are
yes,
audible.
ma'am.
Sir, very elaborate, very informative session. And in our like in district of Devghar, most of the cesarean sections they are nowadays done by the surgeons, not by the gynecologists. And what sir has said, it's really, really a matter of concern that even I should say girl, not a lady of 21 is hysterectomized because of sujan, and I don't know what this sujan means. Is it erosion or anything like that? So we all must fight against this. And sir's lecture, sir, your lecture is really like other lectures that I have heard you. It's very, very informative. And thank you, sir. Thank you for your in this informative lecture. And thanks the organizers for giving me this opportunity to chair the session of a legendary personality, our MC Patel sir.
Thank you, madam. Thank you.
Requesting Subhadra madam, Sashibala ma'am.
Subhadra ma'am was there in the beginning. Let me call her. I saw
She's
Sashibala
still
madam
there.
also.
She's still there. I can see her in the audience, ma'am.
सुभद्रा मैम अनम्यूट करिए अपने आप को आस्क टू अनम्यूट शशिबाला मैम आप अपने आप को अनम्यूट कीजिए मैम हाँ यस मैम सुभद्रा मैम इज अनम्यूटेड नाउ यस मैम
Thank you, sir. Thank you for a wonderful talk. It was exciting. And thank you for giving me opportunity to share your system. I don't deserve it. Privilege. And for your lecture. Thank you, sir.
Thank you.
It was quite wonderful.
Inspire. Can we have Sashibala ma'am's comments, ma'am?
Hello.
Yes, ma'am.
Hello, good evening, sir.
Good evening. Welcome, madam. Yes, Sasibala madam, welcome.
Hello, sir.
Yes.
Actually, I am not feeling well, but I am suffering for the cough and cold. But at time I am good.
Yes. So, any remarks, any concluding remarks from your side?
Sir, it was a very in these days we see ki, hysterectomy is very every patient who come with the following problems and white discharge and pain abdomen, and usually we see in the remote area there is chances the rate of the hysterectomy is going on. So naturally this presentation was a very good, sir. Are we have to say, or we have to uh, uh, with the rural area and all the doctors we have to say कि हमें इसको नहीं करना है, जब भी जरूरत हो तभी हिस्टेक्टमी होना चाहिए. वेरी इंपॉर्टेंट, इट इज द काउंसलिंग टू द पेशेंट. एक्चुअली पेशेंट कहे मन कहे कि मैडम मेरा पानी गिर रहा है या मुझे पेट में दर्द हो रहा है, मुझे बचदानी हटाना है. So, but usually in the medical college we always counseling and we go through the proper channel ki pehle we go for the antibiotics therapy, then we go for the pap smear, then we counseling is very important for that ki the rate of hysterectomy should be good also. So presentation was very good, sir.
Thank you. Thank you, madam.
Thank you, ma'am. Thank you, chairpersons, and thank you, Patel, sir. I request Dr. Shatabdi to please take over for the panel discussion.
Just a few minutes, Dr. Shatabdi, if you don't mind. Dr. Archana has rejoined and she says she's just 5 minutes more of a presentation. So, Dr.
Okay.
Archana, could you just finish your presentation? Dr. Shivani Jha, ma'am, I don't see her here as a last
No, ma'am,
chairperson.
not
So,
there. In the...
yeah. So, Archana, if you could just start, please. Dr. Shipra has raised her hand. Yes, Shipra.
So is my slide visible?
Yeah, yeah. You were at this.
So
You were
you
at
told
stage
me
3.
that thank you so much for bearing with me. Nivedita, you informed me that I had stopped at my connection was lost at this stage 3.
Yes, yes.
Okay. So stage 4, you can see the most distal portion of the prolapse is beyond this TVL -2, and actually it is total eversion of the vagina. Now this is actually a diagram showing comparison of commonly used grading system. So you can understand in most of the system we use introitus as the reference point for grading the prolapse. But in POPQ classification, we use the hymenal ring, which is slightly above the introitus. So this reference point can make overlap of different stages. We are not supposed to go into nuances, but just we have to understand that reference point in POPQ is always hymenal ring. So there is also a simplified version of POPQ classification where we measure only 4 points. BA, BP, CD, that is cervix and the pouch of Douglas, and the cervix if present. That means we are not taking the fixed point, AP and AA. This is another simplified classification proposed by IUGA, but it is yet to be validated. So I will now just let you understand how to do the actual POPQ staging through different diagrams. So it is very important to understand that all measurements are taken in Valsalva maneuver. That is, we ask the patient to strain, except one measurement which we take in non-straining position, that is TVL, total vaginal length. Otherwise, all the measurements are taken in a patient straining position. And the reference point, as I always highlighted previously also, it is hymenal margin. And we have to measure the leading part of the prolapse, leading point of the prolapse. Total vaginal length is measured from the vaginal apex to the hymen after reducing the prolapse. And all measurement inside the vagina proximal to hymen is minus, and all measurement distal to hymen are positive. This I earlier also explained. So what are the requirements for POPQ classification? You need to have a good source of light. Both sim speculum and Cusco speculum are required. You need to have a ring forceps or IS spatula or copper T plunger, which is marked in centimeter. And there has to be a marker to mark the point A and AP. Then you have to have an assistant to document the finding. And how do the patient is positioned? It is in dorsal lithotomy position. Ask the patient to do the Valsalva maneuver. Start with measuring genital hiatus and perineal body. Just when the patient starts training, take the genital hiatus measurement at that point. It is not in non-straining position. Ask the patient to relax, reduce the prolapse, and then take TVL under guidance of 2 fingers and measure the length from vaginal apex to the hymen. Then we have to mark AA and AP on the anterior and posterior vaginal wall after reducing the prolapse, and then do the POPQ staging. So it will be more clear if I demonstrate you these pictures. So you can see this is GH. It is from external urethral meatus to the midpoint of the posterior fortity, and you see the measurements are being taken in the patient's training. The moment the patient starts training and the bulge is out, you have to do the measurement. Next, you can see here, this is the perineal body measurement from the midpoint of the posterior fortity to the midpoint of the anus. This is the total vaginal length measurement. Actually, the prolapse has been reduced, and you have to introduce 2 fingers into the posterior vaginal wall and measure with the length of whatever instrument, whatever gadget you have, whether it is a scale or copper T, plunger, or eye spatula graduated. So after taking these T measurements, you can actually document it in this grid. I already told you this 9-point grid is made like that. So genital hiatus here is 6.5 centimeter. Perineal body comes out to be 2.5 centimeters. So you can easily see this is the defect of the perineal body. And genital hiatus, there's defect in the pelvic floor support. Now we have to measure a point AA and BA. So we have here, you can see the marking is of AA is done in the neutral position. That is the prolapse is reduced, and we have to mark 3 centimeter proximal to the hymen in the anterior vaginal wall in the middle. And then AA point is measured when the patient is actually doing a straining. So at the point of maximal straining, here you can see this is the AA point. So this is actually just a little below the hymen, so it is +1. And this is actually point BA, not very clear in this diagram, but point BA is has come down a little more. So this is kind of point B, which is +3. That is, it is 2 centimeter further beyond the hymen. Then we have to measure AP and BP. So for this, we have to reduce the prolapse of the anterior vaginal wall and the cervix. So for this, we use the sim speculum. So you can see in this diagram, the prolapse part is reduced. And now we have marked the point AP, 3 centimeter proximal to the hymen in the posterior vaginal wall. And then we are measuring AP. This is 3 centimeter proximal. And then we are measuring point BP. So this is the, and then we measure C and D. So C is the most distal edge of the cervix. You can see the measurements are being taken from the hymenal hymen margin of the hymen. And point D is actually the pouch of the Douglas, that is attachment of the uterosacral ligament. So here the pouch of Douglas is not prolapse outside, it is inside the vagina. So we have to introduce our finger and take the measurement. So here you can see the C point was +3.5 and D is -7. So actually this is elongation of the cervix. And these are the grid and line diagram of the complete eversion of the vagina. You can see this is the normal anatomical position and this is the complete eversion of the vagina. You can see, I told you AA can vary from -3 to +3. So it is -3 to +3. BA can vary from -3 to total vaginal length. So you can see BA is actually +8. It is equal to TVL. And similarly, the posterior vaginal wall also is complete eversion. So it is -3 to +3. And BP is also has almost equal to TVL. So actually, when we do the POPQ classification, we make the grid, and if possible, it is better to make the line diagram as well. And you can see this line diagrams of showing exclusively the anterior compartment defect. So you can see the posterior compartment AP is at -3. Point BP has a little bit come down AP, so it is -2, but it is still inside the hymen. C is still inside the introitus, so it is here. And you can see point A has come, it is an anterior vaginal wall prolapse, so it is +3, and BA is +6. And this is a line diagram showing entirely the posterior vaginal wall prolapse. So you can see all the points on the anterior vaginal wall is in the normal position, and AP is +3 and BP is +5. So here is as a very easy question. Here is because I am from quiz committee, so I always put some quiz for you people. So here is 58-year-old multiparous woman who attends OPD with a symptomatic vaginal prolapse. On examination, the POPQ classification demonstrated this. So what is the stage of the pelvic organ prolapse? I think it is easy one. The most distal part.
She has a total vaginal length, so it is the stage 4, I
10.
think.
So the most
10.
distal point is less than TVL -2. So it is stage 3 prolapse.
Yeah.
So you can see here, it is stage 3 prolapse. So what are the pros and cons of POPQ classification? It is objective, site-specific, scientific method, everything is in number. So chances of variation is less, but practically I feel it is not, the variation will be there in measurement also to little extent. But it is important for comparison of result in research setting. Disadvantage, of course, it is complicated, time consuming, you need to have assistant, otherwise we just write in the OPD cystocele, rectocele, androcele, moderate, mild, and we are done. But here we need some time and some specific instruments also. So the key points are the cause of prolapse are multifactorial, but it is important to understand 3 levels of Delancey support. And the pelvic examination should include thoughtful attention to all the compartment, anterior compartment, the posterior compartment, the middle compartment, which is the apical compartment. And the objective evaluation using validated POPQ allows ability to follow prolapse over time and evaluate the results of the treatment. So after we have done the surgery, all the points would be in the normal anatomical position. So thank you so much for giving me time again. Over to you.
We'll move on since we've already taken the opinions of the chairpersons. We won't waste much time. Over to you, Shatabdi. Thank you, Dr. Archana. That was just, as you understood from the chat box and the WhatsApp, that everybody wants your PPTs now. Over to you, Shatabdi.
Thank you, Nivedita ma'am. Thank you, Archana ma'am, Pratibha ma'am, and MC sir for those 3 very enlightening lectures, I would say very pertinent to today's times. We will now move on to the panel discussion. We have a very interesting panel discussion coming up. It's on mastering the skill of vaginal surgery in modern practice. So we have Dr. Suman Sinha ma'am and Dr. Mosami ma'am as the moderators. The experts are Dr. Maya Verma ma'am and Dr. Geeta Sinha ma'am. Can I have the CVs, please? Dr. Archana, Dr. Suman Sinha ma'am is the chairperson of the Vaginal Surgeries Committee of FOXY, we all know. She's also the member of Research and Good Practice Committee of SAFOG. Welcome you, ma'am. She is our first moderator. Our next moderator is Dr. Moshumi Dash, ma'am. Ma'am is a senior consultant and unit head at Tata Hospital, Jamshedpur. Also associate professor at Manipal Tata Medical College, Jamshedpur. Welcome, ma'am. Our 2 expert panelists for the day are Dr. Maya Verma and Dr. Geeta ma'am. Dr. Maya Verma is a retired professor from the Department of Obstetrics and Gynecology at RIMS Ranchi and GMC Haldwani. She's almost close to 50 years of practicing and making a difference to hundreds of lives. Our next expert panelist is Dr. Divya Rashmi ma'am. Dr. Geeta ma'am. Dr. Geeta ma'am is the vice president of the Ranchi Obs-Gynae Society. Welcome, ma'am. We have a very interesting group of panelists today. Our first panelist is Dr. Sujata Hota ma'am. Ma'am is the ex-chief of medical services and HOD of Gynac at Central Hospital, Dhanbad. Our next, welcome ma'am. Our next panelist is Dr. Rita Thakur ma'am. Ma'am is the director of Hari Umesh Maternity and Newborn Care Center, Deoghar, as well as the consultant at Yash IVF Center at Deoghar. Welcome, ma'am. Our next panelist is Dr. Varuna Verma, ma'am. Ma'am is the Joint Secretary of ISOPAR Bokaro chapter and a laparoscopy and gynae surgeon. Welcome, ma'am. Our next panelist is Dr. Reena Banwal, ma'am. Ma'am is a senior consultant in Obs Gynae at Savitri Surgicare and Maternity Center at Dhanbad. Welcome, ma'am. Our next panelist is Dr. Divya Rashmi. Dr. Divya is a director and consultant obstetrician and gynecologist at Swastik Hospital and Urological Center, Chandrapura, Bokaro. Welcome, ma'am. Our next panelist is Dr. Preeti Yadav. Dr. Preeti Yadav is an assistant professor at Tata Main Hospital, Jamshedpur and Manipal Tata Medical College, Jamshedpur. Also the treasurer of the Jamshedpur Obs Gynae Society. Welcome, Dr. Preeti. Our next panelist is Dr. Divya MB. Dr. Divya is an assistant professor in the Department of OBGY at All India Medical Sciences at Deoghar, Jharkhand. Welcome, Dr. Divya. Our next panelist is Dr. Shweta Lal, ma'am. Dr. Shweta Lal is an AP and HOD of Obs Gynae at SBMCH, Hazaribagh. Welcome, ma'am. And last but not the least, our panelist is Dr. Shipra Sharkar, ma'am. She is a senior consultant at Tata Motors Hospital, Jamshedpur, and has special interest in high-risk pregnancy and geriatric gynecology. Welcome, Shipra, ma'am. Over to you, Suman, ma'am, and Moshami, ma'am, for an excellent, looking forward to an excellent panel discussion.
Share my slides.
Yes, ma'am, please.
कैमरा
आपका सुमन दी जूम वाला खुल रहा है।
हाँ हाँ वही देख रही हूँ, एक बार स्टॉप करती हूँ फिर से शेयर करती हूँ। यही प्रॉब्लम ही हो रहा है।
नहीं, आपका बार बार जूम वाला खुल रहा है। आप पहले प्रेजेंटेशन खोल लीजिए।
पहले प्रेजेंटेशन खोल रहे हैं। हाँ ठीक है, पहले उसी को खोल लेते हैं बेटा। मैं थॉट कि वैसे करे तो नहीं हो रहा है।
नहीं, स्क्रीन को मिनिमाइज कर दीजिए और पहले प्रेजेंटेशन खोल दीजिए।
वही खोल रहा है।
हाँ, I hope all the panelists are here. I can see Divya. I can see Dr. Reena. I can see both the Divyas. And then I can see Shweta. I can see Shipra. And I can see both Varuna. I can see Varuna. I can see Dr. Geeta Sinha Manki as an expert is here. And is Maya Verma madam there?
Yes, I am here.
Thank you, ma'am. Thank you, ma'am.
Dr. Sujata also is there, ma'am.
Dr.
Yes.
Sujata is
Good
there.
evening, I am here.
Yeah.
Yeah, can you see my screen?
Yes.
No, ma'am.
हाँ,
Yes,
ऊपर
ma'am.
ऊपर में आपका ये दिख रहा है। आप सिर्फ ये माइक्रोसॉफ्ट ऑफिस को ऑफ कर दीजिए। हाँ
हाँ, अभी दिख रहा है ना?
हाँ,
अभी
दिख रहा है। हाँ,
okay, I'm
अब आप
making
नीचे
full
आ
screen.
जाइए।
Yeah, just
अब आप नीचे आ जाइए। हाँ
okay. So now it is visible.
हाँ, बिल्कुल।
Am I audible?
Yes, ma'am.
Okay.
Yes.
So
Yes, ma'am.
a very good evening to one and all. But before I come to my topic, I would like to thank and pay my regards to our program director, none other than Dr. MC Patel sir, for giving me this wonderful opportunity. And I really wish him a very remarkable victory for the forthcoming elections. And whenever I come to this platform of happy learning, I really become very emotional because I have been associated with him for, I think, 1.5 years. Every Monday at 6 p.m., I was there as MOC. And that was the period where I got the mentorship of Dr. MC Patel sir, and I owe everything, whatever I am today, is because of him. So thank you very much, sir. And I also pay my regards to our chief guest, Dr. A.K. Devdas sir, who is very, very senior gynecologist. And I'm always in awe of him because he was the first person to go to national level being vice president of Foxy. And then I also have my regards for my other mentors, Dr. Usha Nath madam, Dr. Preeti Bala Sahai madam, and also for Dr. S.K. Das sir, and all the senior chairpersons and all my friends for being here with us today. So thank you very much. And now I come to the topic. So coming to my topic, it is complications and challenges of vaginal hysterectomy. And here I am as the moderator, and as moderator, I have Dr. Mausami Das. And as panelists, they all have been introduced: Dr. Dibya Rasmi, Dr. Sujata Hota, Dr. Rita Thakur, Dr. Neha Priya, Dr. Dibya, Dr. Preeti Yadav, Dr. Sweta Lal, and Dr. Reena Barnwal. And as expert, I have my teacher, Dr. Maya Verma madam, and instead of Dr. Archana Kumari, we have Dr. Geeta Sinha Manki. So I start the panel. So I will take some of the questions and then I will give it to Dr. Mausami. So we are grateful to have had eminent teachers like Dr. B.N. Purandare sir, Dr. D.K. Tang sir, and Dr. S.S. Seth sir. They are the persons who popularized vaginal hysterectomy. And I also want to tell you that India is the first country where we have the maximum number of vaginal surgeons. And we are the pioneers in vaginal surgery at the global level. So the surgeon who claims that he never had any complications, they are the surgeons. Because they are either lying or has not operated enough. Complications are good opportunity of learning and improving your surgical skills. So you should not take it as a failure. As Dr. MC Patel sir has also read a beautiful poem of Dr. Atal Bihari Vajpayee ji. So our complications are not our failures. This is the platform where we can learn and relearn. So, but it is imperative to diagnose complications intraoperatively and postoperatively so that the immediate action can be taken. Just a minute. Yeah. So we should always make a habit of two things: to help or at least to do no harm. This has been quoted by Hippocrates. So complications usually occur due to a casual or an overconfident approach. Patience and perseverance are more important than the surgical steps. So don't be in a hurry and learn to respect the tissue, and tissue will respect you. So now coming to the questions. There is a case of abnormal uterine bleeding with 8 to 10 weeks of uterine size, and that is not responding to medical treatment. And she was taken for hysterectomy, but the surgeon is in dilemma whether he should proceed for vaginal hysterectomy or not. So I just put the question to Dr. Sujata. I hope Sujata is there. What are the prerequisites for vaginal hysterectomy?
Good evening, ma'am.
Yeah.
The prerequisites are for a successful vaginal hysterectomy. To start with, it is the detailed history of the patient about the parity and indications, what complaints he is having. Next is the clinical examination for the uterine mobility, size of the patient, size of the uterus. The uterus should be freely mobile and the size should not exceed 12 weeks, although greater size, even up to 20 week size can be removed with increased experience of the surgeon. The vagina should be spacious, and the cervix should not be flushed with the vagina. And next is the there should not be any adnexal pathology, and the indication actually should be of benign indication, and there should not be there should not be any chance of suspicion of malignancy.
Yes, yes, okay. Yes, well said. So you have to do a detailed clinical evaluation first. You do vaginal examination, you rightly said, but this is also important that you do a traction test and you do a speculum, simple viscous speculum. You put inside and see if there is any descent. Where is the cervix? It is at the os or it is below os. So everything is rightly said, and there should not be any pathology. Now coming to the contraindications. So what are the absolute contraindications where you should not try to do vaginal hysterectomy? And this question is for Dr. Rita Thakur. I've heard Dr. Rita has left. So is Dr. Rita there? So I can take this, Dr. Varuna can take this case.
Yes, the absolute
contraindications.
Yeah,
Indications of,
absolute
we have discussed.
contraindication. Yes. Absolute contraindication for the for a vaginal hysterectomy is, first of all, the size usually if it is more than 12 to 14 weeks, then it is an absolute contraindication. If there is any adnexal pathology, then in that case, if there is malignancy, if the uterus is ventroflexed and the mobility is very less, in that case it is an contraindication. If during examination under anesthesia, if we examine under anesthesia, there is a natural, when we give traction to the cervix, there is a natural descent of the even in normal cases without any prolapse also there is a little bit of descent of the uterus. But if even during anesthesia there is no descent, in that case that's an absolute contraindication. And there is then a dimpling sign when we give traction to the cervix, and then we see that dimpling on the abdominal wall. That means the abdomen is adhered to the interior abdominal wall is adhered to the interior surface of the uterus. Another thing is uterosacral angle. In the uterosacral angle, suppose this is our cervix and this is the body. This should not be if this angle is 90 degree. That means you have a very big ball kind of a cervix like in adenomyosis, and there is just a stump of the cervix. In that case, vaginal hysterectomy is very difficult. If the cervix is flushed with vagina and there has been some surgery on the cervix and there is no cervix to hold upon, in that case also
yes,
it is contraindicated. And did I mention malignancy? In case of malignancy, we wouldn't like to do a vaginal hysterectomy. In case of endometriosis, again, it can be.
Not to do. Yeah. So there are some relative indications also, that if the descent is there but it is restricted, if there is narrow pubic arch or there is very limited vaginal space, you can do, but a very experienced surgeon can do. If there is minimal adnexal disease, then also we need a experienced surgeon. In nulliparate, likewise in prior abdominal surgery like CS or myomectomy and broad ligament fibroid, these are not absolute contraindication, but they are the relative contraindication. But it is not contraindicated in cases of CIN, endometrial hyperplasia, benign ovarian cysts. When there is requirement of oophorectomy, we can do vaginal hysterectomy through oophorectomy. And even in bulky uterus, less than 12 week size, we can very efficiently do vaginal hysterectomy. So what affects the vaginal root? How you decide? Baruna, this question again is for you only. How can you decide that this case can be taken for vaginal hysterectomy or this case can be taken for lap hysterectomy or abdominal hysterectomy? What are the points, main points to differentiate between VH and AH?
Baruna, unmute yourself, please.
Now, again, if there is mobility.
Just the point. Don't read everything. Just the points. What are the points? Just there are 4 or 5 points.
Okay, if it is freely mobile, then we can go for vaginal hysterectomy. If again under anesthesia, if when we pull on it and the uterus is not palpable per abdomen, then we can go for vaginal hysterectomy. And it also depends on the experience and of the surgeon. If they think that we cannot do it, then they should not do it. And subpubic arch, if it is very narrow, then it might be difficult. And if there is adnexal masses, then we should go for abdominal hysterectomy or laparoscopic hysterectomy.
Yes. So I hope I have seen Reena Bandwal is there, no? So what is the role of ultrasonography in selecting a case of VH?
Ma'am, good evening, ma'am.
Is there any role? Ultrasound? Can it help?
Ultrasound is very helpful in assessing the patient preoperatively for the feasibility of VH. Most important is the uterine size. If the uterus is less than 8-week size, it becomes really easy. And for 8 to 12 weeks, a little expertise is needed. But for more than 12 weeks of uterus, we can need morcellation or debulking surgery, etc., which is better in experts' hands. And also we can rule out the pathology of the uterus. Suppose it is fibroid, endometriosis, etc., or adenomyosis. We can rule out the adnexal masses or any malignancy, any adhesions and endometriosis. And we can look for the mobility of the uterocervical angle of the uterus, and we can plan the surgery according to the pathology. And if there is space between the uterus and the lateral wall of the pelvis, and ma'am, and if there is any adhesion, if there is any other anomaly in the uterus or any genitourinary abnormality also, we can look for them.
So this way, the ultrasound is very helpful. So every case before taking for hysterectomy, you should do assess by ultrasonography.
Yes, ma'am.
So Dr. Dibya is there. Dr. Dibya?
Yes,
Yeah,
good evening, ma'am. I'm here.
Okay. So we have already, I think Dr. Varuna has already said about the traction and Dr. said cervicofundal sign. But we'd like to hear from you, what is this traction test and what is Dr. Said's cervicofundal sign?
Okay, ma'am. So a traction test is something like we do to check for the mobility of the uterus to see whether the uterus there is any descent or not. So the anterior and the posterior lips of the cervix are held by a valsellum, and it is pulled outside. And if we see that if the level of the external os is above the level of the ischial spines, we say that there is not a proper descent, and therefore this case would not be very suitable for a vaginal hysterectomy. Okay, similarly for Shades cervicofundal sign. Now, this is shown in cases where there is a history of previous cesarean section. In such cases, many times we find that the uterus and the cervix, it is adhered to the anterior wall of the uterus. And in such cases, the cervix is very difficult to approach. So in these cases, if we catch hold of the cervix and we pull it down, many times we find that there is a dimpling or there is a depression in the anterior abdominal wall. And this is the Shades cervicofundal sign. And this is definitely not a case that should be taken for a vaginal hysterectomy, because it will be very difficult to do a dissection and to open the anterior pouch also in such cases.
Yes, rightly said. So before taking any case, we should do always do the traction test, and the same time we'll perform the Dr. Siri said cervicofundal sign, and also about the there is a very important to know the angle between the uterus and the lateral cervical surface. So Dr. Dibya, again I would like to ask you, what should be the angle of the between the uterus and the lateral cervical surface? Which angle is preferred? So see this diagram and tell us.
I think this is Dr. Divya from Deoghar. Dr. Divya.
Ma'am.
Okay. So yeah, the two
Good evening,
Divyas
ma'am.
we have. Yeah, good evening.
ma'am. Ma'am, if the angle
you see both the diagrams and tell us.
Ma'am, if the uterocervical angle is more, then there will be more space and it will be easy to perform the vaginal hysterectomy.
like here, this diagram.
Ma'am, that
Equal.
space is less, so it's very difficult even to put the clamps and all. So it will be a difficult surgery. And if the angle is good, then it will be easy for us to do the vaginal hysterectomy.
Okay, so three things are very important. One is the doctor said, this is Jackson test, and the other one was the just a minute.
Traction test.
Cervicofundal sign and the angle between the uterocervical angle. So we have to keep in mind all the 3 points. So Dr. Preeti Yadav, what are the favorable finding in?
Yes, ma'am.
Yeah,
For favorable.
under anesthesia, yeah, examination under anesthesia.
Once the patient is under anesthesia, we must again keep a check of if there is any contraindication. Thereafter, a uterine size, how mobile is the uterus, and what is the descent of uterus. In addition to it, the sides of the uterus, is that they are free or there is any SOL or occupying lesion or the restriction. And other than these, the length of the cervix in the portio vaginalis is quite significant as a favorable finding, as we can go ahead with the vaginal hysterectomy further.
Okay, thank you. So this Dibya, you are the same, na? Dr.
Yes,
Dibya? Yeah.
Yes, ma'am. Yes, ma'am.
How will you avoid complications in vaginal hysterectomy on table?
Ma'am, before proceeding with vaginal hysterectomy, that anyway, a proper positioning is very important. And of course, in OT, there will be proper lighting and instruments, everything will be there, and patient will be under anesthesia. Then actually, before doing the surgery, we will empty the bladder. And for getting a good space between the bladder and the vaginal wall, we can infiltrate with diluted adrenaline so that the plane for separation will be easy for us. Then when we are approaching, it should be like it should not be in a hurry, and we should take time for even opening the POD. And after opening the POD, you can either go anteriorly or posteriorly, and going posteriorly will be easy, and you will be able to dissect and give the space.
We'll discuss it later. That was only about the points, no?
Okay.
So what are the, Dr. Sweta is there? Sweta Lal?
Yes, ma'am.
Yeah. So we would like to know from you, what are the common encountered complications of vaginal hysterectomy?
Ma'am, like any surgery, the risk of anesthesia is always there. And what we are most scared of is hemorrhage. And of course, injury to vital organs on the table. Like we know the bladder is very near. If we are doing a procedentia, we are scared of the ureter as well. When we are opening the posterior pouch, we are scared of the bowel. The rectum is very nearby. So these are the immediate complications majorly during surgery. Post-operatively, we know we can have complications related to anesthesia, we can have pain, we can have patients complain of urinary retention or maybe urinary leakage when we have removed the catheter. Then we have seen complaints of bleeding, also secondary hemorrhage and infections.
So these were the general complications. There are certain specific complications also. So
specifically because of the position of the patient in lithotomy, many a times we see compartment syndromes, many a times we see nerve complaints because of the pressing of the peroneal nerve or the popliteal area which gets pressed because of the lithotomy position which we give, especially the exaggerated lithotomy position. And specifically because of the any injury to the vital organs there, like the bladder and the bowel, and some complications associated because of too tightening of the vagina or the vaginal shortening. And sometimes they complain of persistent perineal pain because of vaginal surgeries.
So, Dr. Sweta, one more question to you. I hope Dr. Mosmi there. Can you take this question, dear Mosmi? Is Mosmi there?
Madam, I'm there.
So please take this question. Now the real question is started.
Yeah.
And from Sweta only, you'll have to.
Yes, madam. So, Suman, madam, I feel very privileged to be part of your team like to be the co-moderator with the lady, the chairperson of vaginal surgeries. So now to begin with the question, see, as described, the positioning which we do before a good surgeon, the work starts right from the OT. The positioning, actually a good surgeon before scrubbing or after scrubbing enters the OT and first looks into the positioning. You just can't depend on your team or the technicians to do that. You have to position the patient in a way that you are comfortable. The how much of abduction is needed. The patient should be on the edge of the OT table. So all that is the actually beginning of your surgery. So that planning, that coordination, and the extra things what we do actually adds to the success of the surgery. So now the question is, now the surgery has started, but you are unable to mobilize the bladder upward. So we are unable to open the anterior pouch. So how do we now proceed? Now think of two conditions. One is the patient has previous vaginal deliveries, or in a case where there is a previous cesarean section. So that history is very important to be kept in mind.
So,
Yeah, Dr. Shweta.
yeah, so one thing which we like to do is an aqua dissection, ma'am. So either you take 200 ml of normal saline, you put 1 ampule of adrenaline, and it not only helps you in creating a plane because of the aqueous plane, also it helps in minor prevention of minor bleeders. So it helps you create a good field without any hemorrhage, helping you out dissecting. But mainly, like you said, in a case where there is a history of previous cesarean, so we prefer to stay a little lateral to than in the center, as we know that mostly whatever adhesions happen in the center. So what we do is try to avoid the 3/5 medial part of the cervicovaginal area, and we try to go laterally, and from there you create a window. You first do a sharp dissection, you create a window with your finger, you do that both ways, and then you try to meet them in the middle, and thus create a place where you can actually try to be safe and hope nothing goes wrong.
Yeah, thank you. And we start by emptying the bladder.
Yeah,
All the
yeah, we do.
dissection anterior. You have to empty the bladder and start the process. And it is important to keep in mind that sharp dissection helps.
Helps, yes.
So what is Dr. Shade's lateral window? You have answered well. And accessing the anterior pouch.
Yes. So it is all
Now,
it's covered, na? Dr. Shweta has
it's
already
covered.
said.
Yes, yes. So in the same case, now the anterior pouch has opened. With meticulous dissection, you are successful, but now you are stuck with the posterior pouch. So now what are the challenges and how do we now overcome this? How will we proceed? Ma'am, I can pass this question to Dr. Shipra. I think she's not answered.
Dr. Sujata have written. Sujata is not there.
Dr. Sujata is there?
Yeah.
Should
Anyone
I
can say
interrupt?
name is just written because anybody can take it, no?
Yes, ma'am.
So
So
should
you
I
have
take
opened the
it?
anterior pouch now. Now you have to open the.
Please come in.
Yeah.
So anterior pouch is open. Now we are waiting for you to open the posterior pouch. Please come in.
Okay, thank you, ma'am. Good evening, ma'am. I am Dr. Shipra.
Tell Dr. Sipra, yes. You tell us how to
Yes,
open
good
now
evening, ma'am.
the posterior pouch. Yes, good evening.
Ma'am, we may get stuck with it if in cases of endometriosis or previous adhesions, which we could not diagnose earlier. Then we have to navigate through the anterior pouch. If we cannot open the POD, then we should safely open the anterior utrovesical pouch first. And then the dissection of posterior pouch can be done in layers. If we cannot do it, if we attempt for the sharp cut, then it should be done only with proper retraction of rectum because there is a risk of rectum getting open. And we should always remember if we find a fat, it has to be for the rectum. So there we have to hold. We cannot cut open the rectum.
Yeah, so you have to open the anterior pouch and start putting the clamps from the above, and gradually you will see that we are reaching the posterior pouch, and then you can feel from your fingers and then cut it on it sharply.
Yeah.
धीरे धीरे नीचे आएंगे ना तो फिर वो जगह मिल जाएगा हम लोग को.
If one pouch is open, our
It's
work is
very,
half done.
yeah,
It is
yeah.
our
Because
work
you
is
can
half done.
gradually proceed with the surgery,
Yes,
and later
yes.
on it will be
It
very
gives lot of
easy to them.
confidence. Problem arises if we are unable to open, like
And
difficult to
reopen
open.
the pouches. Yeah, both the
Yes, yes.
pouch. Yeah.
If one pouch is open, our work is half done.
Yes.
Thank you for the answer.
Yes.
Thank you, ma'am.
So the surgery is successfully completed and the patient is shifted to ward. And now after 24 hours, she's complaining of severe headache and vomiting. So what could be the cause and how will you help her?
Rita is not there, I think.
No, Dr. Lisa Thakur is not there. Any other panelist can.
Anybody can say.
Ma'am, patient can be suffering from post-surgery spinal headache. So we have to maintain hydration. We can give her IV fluids, and orally we can increase her fluid intake. Patient has to lie down supine without any pillow, and we have to give her caffeine containing liquids. The patient.
Yes.
And we can and to prevent hypertension, we can spinal headache. We have to use a lesser gauge spinal needles. That will
That is very important.
prevent.
And also, you can give vasopressors like Norad.
And pre surgery also adequate hydration of the patient is important. Preloading of the patient.
Reloading is also very important.
Yes.
Yeah, early recovery after surgery, ERAS, following the ERAS protocol.
Yes.
पहले तो नहीं देते थे ना, so earlier we used to have that spinal needle that was very, I mean, बहुत वो thick होते थे ना spinal needles.
Nowadays some 26 gauge needles.
26 gauge is, I mean,
very good.
But then also we should know if this type of complications arise. So again to the Dr. Varuna, what are the complications of lithotomy position during vaginal surgery and how will you manage?
Some background noise is still going on.
Yeah, Dr. Sujata, please stop talk. Can you mute yourself? Dr. Varuna?
Yes, ma'am.
Lithotomy position में क्या हो सकता है?
Lithotomy, because of lithotomy position, there can be edema and muscle edema is there, and compartment syndrome is there, and which can further increase due to edema. And it is important to recognize that, and sometimes we have to do fasciotomy to release the pressure. And then there are nerve compression injuries, popliteal nerve, sciatic nerve, and peroneal and femoral nerve can be there due to stirrups. And to prevent it, we should pad the stirrups with soft cotton, and so that there is not, and the surgery time should be minimal. If we are not able to do it in a particular time, there is no point in struggling for hours together. So it is also important to limit the surgery time. And then deep vein thrombosis is another complication which can occur especially in obese patients and elderly patients. We should be very careful about deep vein thrombosis in obese patients.
So we have to be very choosy in buying the. Just a minute. We have to be very selective in purchasing the stirrups. It should be. It should have a pad and it should have the proper level.
Yes, yes.
There nowadays we are getting very nice stirrups, so we should try to have those stirrups in
As
our
Dr.
opinion.
Maushami madam earlier said that we should see the position ourselves. Sometimes the abduction is too much or the adduction from the thighs is too much. So we should look into the positions ourselves, whether it is positioned properly or not.
Yes. So that is very important. Even our assistant, we should be very careful that our assistant does not lean
Sometimes
upon
they lean upon
the patient's thighs.
You have to be very careful. Yes.
So this point, because I have kept this because this is very important. So many times I have heard patients telling, "पैरों में बहुत दर्द हो रहा है," even because our patients are fragile and they are aged also, no? Because of the age,
Yes.
they are a little bit weaker, and then if they have pain, they are very, very worried about that. They are not worried about their surgery, it is done properly or not, but they are उन लोगों को पेन से बहुत तकलीफ होती है. So we
Yes,
have to be
madam.
careful. This is a very,
And especially if the patient has history of some orthopedic surgery, suppose
yeah.
some knee replacement has been done. So that again we have to keep in mind when we are positioning the patient.
Yes. We have to be the patient friendly होना चाहिए, and surgery से भी ज़्यादा important है to care the patient while operating.
Yeah, cautery plate, position of the cautery plate, all that, the positioning is very important.
Everything, so that patient should be comfortable.
Padding,
Surgeon
proper
should be
padding.
comfortable, assistant should be comfortable, and patient also should be comfortable.
Yeah.
So case 2, Masmi, please take this case.
Yeah, 45-year-old lady, 14 to 16 weeks uterine size with multiple fibroids and heavy menstrual bleeding. Is now posted for NDVH. You are stuck up after opening the anterior and posterior pouch. How to proceed? That is, now the uterus is big, so we have to now remove the bulk of the uterus. So, Dr. Preeti Yadav. So how do we remove this uterus? Are you there, Dr. Preeti?
Yes, ma'am. We are going
Yeah.
ahead with the sort of debulking procedure. For these procedure, we need to take care of anterior and posterior compartments so that they are properly retracted. As doing the procedure, we might injure both bladder and the posterior rectum, as we have already opened the anterior and posterior pouch. So first is the debulking. For debulking, we have to look after that once the uterine artery is ligated, we go ahead so that there is a minimal of hemorrhage and the uterus is minimized in a grossly enlarged uterus. Number 2, we can also think about coring procedures. Coring is usually done with a smooth globular uterus and circumferentially incising so that the matter inside is reduced and there is further descent and we can go ahead with the surgery. Other than this, dividing the uterus into 2 halves by holding it at 3 and 9 o'clock procedure, that is called as this hemisections of the uterus. This will further aid in our mobility and going ahead with the surgery. Morcellation with a wedge morcellation and removing the uterus in the piecemeal type of thing. Or Preos technique, that is systemic anterior morcellation and entire enucleating. In other than this, a myomectomy, if you can just encountering any myoma in between the surgery, you can remove it as an in photo. Removing a larger myoma is easier as compared to small myomas during the surgery, that as it will take a lot of time and will need further hemorrhage as well.
Here I have a doubt, ma'am. Ma'am, I have a doubt. Sorry, ma'am, to disturb.
Anything more?
One doubt, ma'am. Do we these debulking surgeries are done even before we have clamped the uterine arteries? So will it not
actually better to do after
clamping
uterine arteries? It is not written in the book, also not indicated. We should try to operate the uterine artery, both the sides, or yes, and then you proceed with the debulking or bisecting or whatever you want to do. Routinely, we are doing that. Have you done morcellation without?
Ma'am, actually, we are not taking these big surgeries for uteruses for the vaginal hysterectomy. Not more than 12 weeks. I am not doing. That is why I was asking.
If you have a small fibroid also, then also it is better that you do bisect and remove it so that you'll get more space while operating.
Ma'am, even though these procedures may sound to be very simple, but actually they are very difficult procedures once you do it, because usually not morcellation, but coring technique is what we attempt after doing a laparoscopic surgery also, if there is a big size uterus.
We are
So
doing
the
coring,
uterine, yeah, we are doing coring, but it is
Yeah,
not
we are
as
doing
easy as it sounds. And especially because after laparoscopic hysterectomy, the uterines and everything is taken care of. Everything is there. There's no chance of bleeding. Still, the procedure is not very easy, taking out a big size uterus from the vagina.
But what in my practice, I do bisection. even for the large uterus. And after bisection, I see whatever comes in the way. You say it is a fibroid, it easily sells out.
Yeah, agree, ma'am.
So,
Bisection helps a lot. Yeah.
yes, instead of these things, whatever it is written, these are all theoretical, but practically what we do, and today also I was watching a very nice video of Dr. R.K. Purohit sir. He was doing vaginal hysterectomy under local anesthesia because the patient was a high risk case and she could not undergo laparoscopy. She could not undergo hysteroscopy. So he had the only option of doing a vaginal hysterectomy under local anesthesia. Just he infiltrated xylocaine and did it. It was fantastic surgery. What he did, it was a very big uterus, and the patient was, I think, 60 years old lady, and he did bisection and very nicely he removed the fibroid part. It's a big myoma. It came out so easily. जैसे प्याज निका छिलका होता है ना वैसे ही वो निकल गया. So even I have done like that. So I wanted to tell you, just if you ligate the uterine arteries bilaterally, then you will not be worried. You can go easily ahead. So is it clear? Can we go further?
Yes, ma'am. Especially using a deep speculum, sim speculum with a like broad and like wider speculum, that helps. And some you will find some speculums also which has light. So the speculum which has light at one end. So then that gives more visibility inside. I've seen in the conferences. So now the surgery is completed and the patient is shifted to the post-operative ward and the patient collapses. So what can be the cause? So how do we manage? Ma'am, whom to pass on the question?
Yeah, I'm here, ma'am. Yeah. So if a patient collapses in the post-operative room, the first care to the surgeon would be to think about a hemorrhage or bleeding. Okay, so and this bleeding could be either from, it could be primary due to the slippage of a ligature, or it could be bleeding from the tissue between two stumps, or it could be from the incision. And especially in vaginal hysterectomy, there's a lot of dissection that is done. And so minor oozing can also lead to hemorrhages during after hysterectomy. So the first thing is should be that the hemorrhage, primary hemorrhage because of the slippage of a ligature or something. The hemorrhage can also be reactionary because in the post-op period, once the effect of anesthesia wanes off, then naturally the blood pressure rises and it could reopen blood vessels which were early not bleeding. So again, reactionary hemorrhage could be one cause. And again, after the effect of adrenaline or vasopressin that we use for aquadissection, after the effect of that is also wanes off, again, hemorrhage could be possible after that also.
Yeah. So mostly it is a vasculature, the slippage of a major vasculature. If there is a collapse, patient is collapsing, so it's a major vasculature, there is a slippage. So how do we prevent? What are the preventive steps intraoperatively?
Okay. So intraoperatively, we have to be very careful about hemostasis. That is one thing. So to prevent bleeding during operation, first of all, the surgery should be taken up in the post-menstrual phase because it is then that the vascularity of the structures is the least. Secondly, the patient should be comfortable, the surgeon should be very comfortable, and the field of surgery should be well illuminated. That is another thing. Any minor oozing should be taken off, can be taken care of by electrocautery, and any major bleeding that is occurring during surgery should be ligated properly, right? The surgery should be done, dissection should be done very carefully. That is another thing. And
Yes, okay. It's done,
okay.
I think. Yeah.
And the use of electro energy sources these days,
That
like
is very
ligashore.
important. Yes. Yeah.
That
I
is
wanted to tell
ligashore.
you that. Yeah.
Yes, that is very
So
helpful
that
in
you can
reducing
go
blood
deep
loss.
into the surgery. If you don't
Yeah.
have that bike lamp, then it is very difficult. And you should have right angle also with you. These are the things, the bike lamp, that is the energy sources, and the right angle for for doing self-injectomy. It is good. or long artery forceps. That will also help you. So I think this we have done, so I'm not going to.
Yes, and after surgery, vaginal packing is also very essential because that also helps to reduce the dead space, and pressure caused by that pack also reduces bleeding during after operation.
Nowadays, we are not doing vaginal douche. Are you all doing?
Douching is we don't do, but packing we always
Packing
do.
we are doing, yeah.
Always
But
do.
nowadays,
Mm,
the
vaginal
surgeons, our senior surgeons, they don't even give vaginal packing. I don't know why, but we are in a habit of giving vaginal packing. Yes.
Yeah, even we practice vaginal packing.
Yes, but the very efficient surgeons, the like Dr. PC Bhapatra sir and Dr. RK Prohit, they say no, no, no,
He
no.
does the
Yeah, they are the pioneers in surgery, vaginal surgery. They said no, no, no need. You just check all the bleeding points, and if there is no bleeding, then no need. But I don't
No
agree.
need.
Yeah. So case 3, Mausumi. This is a case of precedentia. Just go through the cases.
A case of precedentia was taken up for vaginal hysterectomy with repair. While making the anterior wall incision, you have opened the bladder. So now there is a bladder injury while doing a vaginal hysterectomy. So what are the surgical steps where bladder is at risk of injury? So who would Dr. Neha Priya? Yeah, Dr. Divya.
Dr. Priyanka Rai has very nicely shown you how to repair the bladder injury, and she has done our
yes.
Of our work is done by her.
So,
Bolo.
So,
yeah, somebody can just we can just quickly just
because we have 10 minutes only, I think.
Yeah, so bladder is a very forgiving organ. So bladder should be repaired in 2 layers, definitely with Vicryl 20 or 30 or even chromic 20. Bladder should be repaired. The first layer should include the mucosa and the muscular layer, and the second layer should include the serosa, and the serosa is taken so as to bury the first layer. Now the suture should be it should be watertight, and tension-free sutures are a must. So the suture should be tension-free so that the surgeon is tension-free after that.
And it should be in 2 layers, you have already said. And it will be continuous. You're not giving interrupted. Continuous.
No, continuous.
Continuous. And I think everybody must have undergone this.
Yes, yes. And when and how do you repair the bladder? Is it before hysterectomy or after hysterectomy is completed? Part of the question.
Ma'am, for personally, I would like to repair the bladder as soon as I identify it, because the stress of leaving an injured bladder would be too much of a pressure on me.
And even you can forget also, na?
Yeah,
Yes,
no, yeah, we can forget also.
This is a
But
quiz
I'll
type of
always
question. Yeah, everybody, whenever you notice it, you have to complete the suturing part and then move ahead.
And then proceed for hysterectomy after that.
Now, in the postoperative period after removal of Foley's catheter on 14th day, patient complains of leakage of urine. So what are the causes? Dr. Shipra Sarkar. So how do you differentiate the causes of postoperative urine leakage? Now, bladder has been repaired, and then we have kept the Foley's catheter for 2 weeks.
When we remove CBD and then we find that there is a leakage, it can be due to incontinence that was already there and it was masked before surgery because of large cystocele. So when we have corrected cystocele, the genuine mild stress urinary incontinence has become apparent. And it can be de novo SUI also. That that procedure we don't do so often, Leafort's colpoclasis. So it can happen just because we have done surgery and the angle has got misplaced, that cervical neck has got misplaced, and it can produce stress urinary incontinence. It can be due to
dreaded problem is the fistula.
Yeah.
Fistula,
Because of the surgical incompetency or by mistake. Yeah. There
That
can
is
be
the
two
most
incontinence.
problem. Yeah, that can be blindly cutting or clamping or cauterization could have caused fistula.
Unknowingly, surgeon has not done it. जान के नहीं किया है, but it can happen.
Definitely. But if we detect it after 2 weeks, then we cannot repair it then and there. Then we'll have to wait and repair it after 6 weeks once it
How do we diagnose,
heals.
Christina? How do we diagnose? How do we confirm?
That we
CT
have to do
urography.
by,
Test.
nowadays we prefer
Body
CT
test, na? क्या
urography
test?
and urodynamics.
You put
We used to do
Earlier we
in
used
our
to do
PG,
methylene blue
during our
dye
PG
test. Yeah.
times.
Yeah,
we used
that
to
was
put
the dye
methylene
test.
blue inside the
Yes, three
Yeah,
swab tests we used
three
to do.
swab
the
test.
vagina,
Yeah,
and then marking was there. Upper part is wet, or the middle part, or the last part.
true.
That way used to
Ah,
define.
but nowadays we don't do anything
But
else. We
nowadays we
just
have
go for the CT.
urodynamic study and this CT
CT
urography.
urography. Yeah.
So that days are gone for the diagnosis.
Those three swab tests is now only in books and
Yes,
we
only
don't
in books. We
perform.
had
Still,
read
in
it in
that
our PG
bedside,
times.
it is still important.
So treatment part, please. How will
For
you treat it?
treatment, for
Just a
stress
theoretical,
urinary
yeah.
incontinence, for stress urinary incontinence, we have to put the tape, that is transobturator or transvaginal. Transobturator is easier. And in case of proper VDF, we have to wait for 6 weeks and then repair it. We don't do it. We have to refer it to the neurosurgeon.
Neurosurgeons. But then for knowledge, this is
Yeah. There is flap is created by dissection, and then we do the Latz-Coast repair. And then cystourethropy with DJ stent for ureteric vaginal fistula. That is the higher referral centers are used for ureteric reimplantation or end-to-end anastomosis. That is a dreaded
completely
complication.
heard
We don't
about
want
DG
that.
stent. Rarely,
DJ stent is
yeah, we have
ductly
heard about.
apply. Yeah, we have urosurgery that goes side by side. So we have seen so many DJ stent being put. We at times do it during the surgery also. We put it and then complete the surgery and then leave it there. So that I have seen. But this end-to-end anastomosis, ureteric reimplantation, I have never seen. That is
Could we get some opinion from the experts? We have two experts with us, Dr. Maya Verma madam and Dr. Geeta Sinha
Yes.
Manki madam. So could you have some opinion from the experts?
Maya madam, are you there?
Yes, I am here.
मैडम थोड़ा बताइए हम लोग को यदि
I'm
फिस्टुला हो
hearing
जाता
that
है
so giving me full attention. Now, my opinion is that all of the panelists were well read. They have come here with all good preparation. And the questions are only one thing I think that they have missed. Then, while assessing the patient before putting them surgery or starting the surgery, one thing they have not assessed whether this lady is having SEY from beforehand or for she is having cystosil, urethrosil, first degree, first lower one third of the descent, upper two third descent, and all these many a time even though their lady is not having prolapse, but the lady is elderly patient usually have this urinary incontinence, stress urinary incontinence. So they have just missed while assessing the patient and doing pelvic examination, seeing the degree of the descent, anterior part, posterior part, lower third, upper third, all the tests they have done. Only one word they missed. That is the assessment of the leakage of urine while straining or coughing. So that is one thing they missed. But while discussing the answer the questions, they have covered all those things. That those things that it is not injury, only it is they missing the diagnosis before starting the surgery. If they would have assessed that stress urinary incontinence, they would have placed the sutures. And even then, the complications, the retention of urine, or the difficulty in passing urine, then post-operative, but the special attention while doing the anterior colporrhaphy, and how at what level they should place the suture, how deep they should take the suture, how the uretrovesical angle should be maintained, up to what these points, these more practical points, not theoretical, but it is the practical points. So I think most of the things they have covered very well. And one more thing, that is as they are doing the more practical things. One more thing, sometimes the latest things is that if the vaginal canal is very narrow and subpubic angle is narrow, and then sometimes while doing vaginal hysterectomy, it is very difficult, becomes very difficult to put the clamps in uterine vessels or in the side vessels. That what to do when there is no space, very narrow vagina. And even then you have to say latest things have come up. So you can ligate the vessels without putting the clamp. And for that the newer devices has been arrived. And though I have not used it, but I have read it. Then that is the
हम लोग डिस्कस
yeah,
किए मैडम
yeah.
बाइक लैम्प के लिए ट्राइंग बाइक लैम्प वी हैव टू यूज
तो
इट
क्लैंप पुट करना कभी कभी बहुत डिफिकल्ट है, इतना नैरो होता है कि क्लैंप को स्लिप
मैडम
करने का चांस
एनर्जी
रहता है.
क्लैम्प है मैडम एनर्जी सोर्सेज दैट इज वी कॉल इट
Yes,
ट्राइंग बाइक लैम्प
yes. It is not yet
वी
very
आर नॉट टेकिंग
introduced into the
सूचर्स या
practice. Yeah. So in this, that the this energy sources is that they put the electromagnetic devices. They put that electrodes are put there in the blood vessels, and they melt the collagen and the elastin tissue that obliterate the lumen of the blood vessel, and they cover up to the 3 to 7 millimeter of diameter of the blood vessels. Though I don't know how far they are for this, the one has to become very trained personnel,
Yes,
so
madam.
that I can judge the how wet it can be. And another one thing, that is if there is no place, I have seen my professor putting the ligature without placing the clamp. They pull the uterus on one side and place the suture without placing the clamp. And the suture should be tight enough and they should be on both the side, and then they cut. And it was beneficial. So it is the modification, though it's a very old technique, but I remember this thing.
Yes, ma'am.
And one more thing, that the hydro dissection, that means that the girl has said ki, to get the good plane and the minimize the bleeding, do you use to infiltrate the normal saline? Yes, the infiltration of normal saline gives a very good plane and very easy dissection. And at the same time, it controls the oozing from the cut dissected surface. So these things I observed, and all I'm very much satisfied that the WAP, you people are so well read and so well prepared. Many things I have forgotten. I have revised by attending your panel. And that one thing which I have forgotten done several time, but yet I forgot that when there is difficulty in opening the anterior pouch, I used to put that. I didn't read it in the book at that time, but incidentally I approached through the lateral side and went beyond that and then reached the anterior center of the anterior pouch, and it was so easy to open the anterior pouch. And one more thing, see, you have mentioned that navigation from the anterior pouch when the difficulty in opening the posterior pouch.
POD, yeah.
Yeah.
Yes,
So
true.
I'm so happy that you have asked me to have this position. And I'm thinking, I don't know whether I have done justice or not, but I heard very sincerely each and every point. Your questions are so many questions I have forgotten. I remembered, I revised myself. Thank you very much, bhai.
Maya madam expert.
Yes, Maya.
Yeah,
Very
whatever
well
I have put here,
commented.
madam, I have learned from you all only, and then only.
ए उषा दी, तुमने अपने पोजीशन को
हाँ,
जस्टिफाई किया कि नहीं? बोलो भाई, ये लोग लड़की लोग तो हमको
बहुत
एकदम
बहुत
अचानक से
जस्टिफाई की तुम, बहुत जस्टिफाई की तुम, और तुम्हारा कमेंट आई एग्री कंप्लीटली that these girls have read very well and presented the case and
anything you
very
learn when
very
you
good.
learn in trouble.
Yeah, I
And
did learn something. I did learn also something that
yeah,
in
madam.
your technique of putting the, you know, electromagnetic
Yes.
use. Yes, yes. Maya,
I have
you
not
did
still
very
not
well.
have used
Thank
it,
you.
but it's a newer technique and it's a very good
Yeah.
technique, but you have to
I
expert in it.
haven't seen it. I have not seen it as yet.
I would like to see.
Let's move to the
Suman, are we
जी मैम
using it in RIMS? This?
हाँ मैडम
Are
हम
we
लोग अभी
using
किया
it?
ना या मैडम हम लोग एनर्जी सोर्स यूज करके वी हैव डन इन ड्रीम्स अभी वेजाइनल
अरे
सर्जरी
किसी
वर्कअप
में
किया
बुलाना मुझे जब तुम एक्सपेक्ट करती हो. I want to see it.
जी मैम
Okay.
Thank
Thank you.
We have Dr. Geeta Sinha Manki with us
Yes.
as the
Good
next
evening,
expert.
all. Can you hear me?
yes
Can you
Yes.
hear me?
Yes, yes,
Hello.
we can hear you, Geeta. We can hear
Good
you.
evening, all my seniors, Program Director Dr. M C Patel, and our chief guest, Dr. Alok Devdas, sir. My regards to our guest of honor, Dr. Usana, Dr. Pritiwala Sahai, and Dr. S.K. Das. All my seniors, colleagues, and dear juniors, my good wishes to you. It is a very, very elaborate and beautiful panel. I thank to Dr. Suman for such a, she is a very good moderator, Dr. Mosmi and panelists, Dr. Sujata, Dr. Rita Thakur, Dr. Varuna, Dr. Reena, Dr. Divya, Dr. Priti, Dr. Rita Lal and Dr. Sipra Sarkar. This was a very informative and it is revised all my knowledge also. But one thing I want to say, we should screen for the tuberculosis also. If there is tuberculosis, the later on post-operatively after 1 or 2 months, she start incontinence, dribbling of urine or all these complications starts. Tuberculosis is one of the very vulnerable I mean to say complication, which after a very good surgery, even it gives a complication later on. And patient will come, देखो तो मेरा पेशाब चू रहा है. आप तो बस सब कुछ मतलब 2 महीने बाद 1.5 महीने बाद पेशाब चू रहा है तेरा. फिर you go for the tuberculosis का पूरा वो करो. You do the screening and you will get, if you are not doing the screening, you start the blindly the anti-tuberculosis and the dribbling or incontinence will recover. I saw several patients like this. Second thing, a very good incidence I want to say. There was a patient, she was for around 35 years. She had a very big fibroid. Can you hear me?
yes we are hearing you
Okay.
Di.
She had
Yes, I
very
can hear
big
you.
fibroid, 11 centimeter or more than that, a big fibroid. I said, okay, I will go through abdominal route. She said, the बचवा कैसे पैदा होला? तू बताओ तो हमको क्यों पेट फाड़ेगी? And truly speaking,
Very
then I tried
interesting.
it and removed it from the vaginal route. Really, it was a very good experience. Anyway, my thanks to all and your presentation panel, everything was so complete and very good. Thank you very much. Good evening.
Dr. Patel, we can take some more questions. Nivedita,
Dr. Patel, thank
sir,
you for
should I
thank
stop
you for
here?
keeping me in this. Suman, one thing,
madam.
one thing
बोलिए ना, madam.
more I have to say that after surgery on 4th, I have seen one case long ago that patient was having leaking. Now my boss was scolding me. You have not assisted well. We have left the fistula. But then you know what was that? That was the peritoneal fluid. That was not urine.
Oh, acha,
So this
okay.
can also happen if the peritoneal suture is not proper.
Vault is not
So
well.
some
Vault is
fluid
not
was
closed.
leaking from that thing, and then after 2-3 days it has gone. And I got so much scolding from my boss.
Boss is boss, no,
Madam
madam.
is rightly
One
pointed,
more
madam.
thing.
This we'll
Boss
take
is
care of this.
always right.
Human in one we have missed pointing out in long standing case with procedencia, unfortunately the kinking of the ureter,
Yes, madam.
pulling up the ureter or the clamping in the ureter can cause ureteric fistula. And then in spite of doing anterior colporaphy very well, sparing the bladder, the ureteric fistula can also occur. So we have not to forget it. This is also possibility of this.
I think this I will put one more question. I'll add this one. I will add.
Yeah. And one thing let me thanks Dr. MC Patel that after such a long period he has remembered me and placed me in this very position to revise myself very well and to interact with all of you. Thank you very much, Dr. Patel.
Thank
And
you,
wish
madam.
all
Thank you,
of good
sir. I
wishes
don't
for
know.
your success in this election.
Thank you, madam.
Stop sharing.
I will eat a big laddu.
Yes, of course, yes.
Yeah.
Thank you, sir. I don't have much practice to speak and don't have to give presentation opportunity to give presentation. After long gap, after at least 5 years gap, I got the opportunity to say something. Though I was not prepared because I could not get time all the time.